This conference will now be recorded.
Sorry. If you haven't been introduced already, a couple of us over in each residency program were interested in the fact that, or interested in the concept of journal club, but critical appraisal isn't really something you come by. However, evidence-based medicine is probably now more important than ever. So that was the inspiration behind the concept of making this day. I think I have to stress to say that none of these papers are scientific. They're meant to be fun. I hope you've all had a chance to look at the full texts and read through them. They're quite interesting, despite them being a little bit ludicrous. But hopefully that's going to help you with some of the study designs and core concepts of critical appraisal, as we're going to see throughout the day. So without further ado, we're going to start with the resident presentations. This is going to start with Team Stat. Dr. Tasneem, our R1 from Zayed Military Hospital, is going to take the stage now. And the topic there is Q fever, the superstition of avoiding the word quiet as a coping mechanism. It's a randomized control trial, as are all the others. And I am going to let Dr. Tasneem explain the rest. So again, fair warning, this is everyone's first attempt at trying to dissect a paper. So it is, though it is a friendly competition, it is not meant to be a fierce competition. So guys, try to cool it and let's see what we can accomplish today. Tasneem, stage is yours.
Thank you, Anzal, and greetings all beloved colleagues, and special greetings to our speakers and colleagues from Tawam Hospital. So as Ansel said, can you share the screen with me? Oh, okay. Okay. As Ansel said, I'll be representing Team Stat for the day. So, woohoo, Team Stat. Can you see the slides? Can you hear me?
Looks clear. Yep.
Great. I'll just move this. Okay. So let me first start with introducing the team members. So we have our senior Neha, she's R3, and then there's Faria R1 and Lola R2, and finally me. There's a lag in the presentation. Okay. So together we'll be appraising an article titled Q Fever, the superstition of avoiding the word quiet as a coping mechanism. It's a randomized controlled trial, non-inferiority type. Allow me to skip the authors. It was published in the British Medical Journal in December 2019. And in case you're interested to know, this journal has an impact factor of 27.6. So we'll go through the article, basically the abstract. So basically, there's been long-held belief or a superstition that the utterance or saying the word quiet in the beginning of any clinical setting has a negative impact of increasing the workload. And here's come the aim of our article. So the aim of the article was to determine the validity of this superstition. So to achieve that, they conducted a controlled randomized controlled trial, non-inferiority type, in which the participants were the duty members of the microbiology department in Lancashire Hospital in UK. So they conducted the study over 61 days, which also happens to be the sample size of the article. So it was almost evenly divided into intervention group of 29 days and control group 39 days. So basically, the participants would open a sealed envelope that is prepared and randomly allocated into either saying today will be a quiet shift versus avoiding the word quiet. And they measured the outcomes, which is basically the workload, objectively in terms of clinical episodes. And clinical episodes means either phone call, significant results or validated results that need to be processed by the duty member during a period of 24 hours. And they had a predetermined non-inferiority margin of, let me minimize this, yeah, of 30 clinical episodes, which means for a shift to be considered busy, it has to exceed this margin, or in other words, increase the workload by more than 30 clinical episodes. However, so the study results actually showed that there was a mean of 144 clinical episodes of the intervention group, or the days where the quiet word was said, versus only 139 in the control group, with a mean difference of only 5.9 days. And the confidence interval was from negative 12.9 to 24.7. Now, if you see here, the upper bound of the confidence interval has not yet crossed the predetermined non-inferiority margin, which means there was no significant increase in the workload in the days where the quiet word was said. Okay, so based on these results, they concluded that they refused the superstition of that the utterance of the quiet word increases the workload, and therefore it shouldn't be avoided. So basically, that was a review of the trial, and we'll be erasing the article and through answering a set of 13 questions. And Neha starts with the first question, stating that whether the study question was relevant. And Faria quotes from the study that the question was whether the utterance of the word quiet in a clinical setting increases the workload. And Lola thinks that this is a relevant question and it can be applied to emergency field. However, she raises another question of how popular this superstition in emergency medicine, and if it's popular in the Middle East as well. Now, there is no much evidence in the literature. However, personally, I thought it's a weird belief, and I didn't think it could possibly be that common in Middle East. But what do I know? I'm just an R1. So it turns out that actually it's a common habit in the emergency medicine field, and especially in the Middle East, according to my colleagues' experience. So according to this, it can actually apply to the Middle East and emergency field. So yes, the question is relevant. Second question, does the study add anything new? And again, Faria quotes from the findings of the article that uttering the word quiet does not significantly increase the workload. So the answer for this, according to Lola, that no, it's not adding anything new. And I actually agree with her, because yes, there is a limited evidence, and probably this is one of the few articles that actually studied this phenomena. But again, the result was much expected. Moving to the third question, Neha asked whether what type of the research question was being asked, and Faria elaborates that in a population of microbiology team working in a clinical shift at Lancashire teaching hospitals in the specified period, whether saying this day will be quiet versus avoiding the word quiet increases the workload. So Lola interprets that by saying that this type of question is determining whether an intervention is worse or inferior to the standard treatment. In our case, the intervention is saying the word quiet, and the standard treatment is avoiding the word quiet. Although, as we said before, there's been no much evidence that avoiding the word quiet actually drops or decreases or result in no increase of the workload. So it can be considered as a standard treatment. This takes us to the second question, or sorry, the next question, whether the study design was appropriate to this type of research question. And Faria refers to the article saying it was a prospective randomized control non-inferiority study. And actually, yes, this is the exact type of study that would answer this type of research question. And Lola further elaborates, saying that randomized controlled trials are actually the second most strongest evidence in avoiding the bias. Fifth question, and we start with the methodology. Neha asks if the non-inferiority margin was based on clinical and statistical reasoning. And the answer, according to the article, was that the margin of non-inferiority was pre-specified before this study by the clinical judgment of authors and colleagues. So unfortunately, the answer would be no. It's clearly and purely subjective, subjectively derived, rather than clinical or statistical reasoning. Okay. Further assessing the methodology, and Neha asked if the test was stating a hypothesis. And according to the article, the null hypothesis for the study was that the utterance of the word quiet increases the clinical workload by no more than an average of 30 clinical episodes daily. So yes, there was a stated hypothesis and it was tested throughout the article. Is the sample size calculated correctly? Let's see. Again, according to the article, the sample size was 61, and it was calculated based on data collected in a period of 30 consecutive days in January. And they found a mean of 156 clinical episodes with a standard deviation of 41. They used the power of 80 and a significance level one-sided of 2.5 and a margin of non-inferiority that is predetermined of 30. And they were assuming there's no outcome difference between the two arms. So let's check. According to this online calculator of the sample size for the non-inferiority trials, as per the determined parameters, the needed or the required sample size is a total of 60 days and 30 per group. So it's actually matching or almost matching the sample size of the article. So yes, it had a correct formula and adequate sample size. The next question, were proper methods of allocation and concealment and blinding used? So we're assessing further into methodology. And according to the article, randomization was performed prior to the study using a software program by a statistician. However, the randomization was not further stratified. This means they were leaving a chance imbalance between the baseline groups in terms of factors that might influence the outcome. Namely, weekends were weekdays distribution, for example. Concealment was actually performed using a sequentially numbered of 8 envelopes, as we mentioned earlier in the abstract. And according to the blinding, they couldn't possibly be blinded towards intervention. Okay, so if we were to answer this question, yes, there was a proper methods of concealment and allocation, despite the fact that there was a lack of stratification. And actually, the authors were trying to minimize the bias of this by repeating the analysis after adjustment to the weekday and bed occupancy as a potential predictors of the workload. However, coming to the non-blinding fact, actually the outcomes were objectively measured, so there is no chance for bias by knowing the intervention by the participants. Next, was the study performed according to the original protocol? Now, referring to the article, they stated that they developed the study and they followed the SPIRAT protocol, and it was actually reported according to the consort guidelines. As mentioned earlier, they calculated the sample size based on data taken in a busier period actually during the winter, and it was then applied in a quieter period. So they planned and they undertake blinded sample size re-estimation in the halfway, and they actually found that it's slightly lesser standard deviation, and by default, a slightly higher power of the study, of the procedure. So they actually proceeded with the original protocol, and they excluded or they ignored the amended sample size. So the answer for this question, yes, there was a protocol and it was followed properly throughout the trial. Were the statistical analysis performed correctly? So now we're moving from the methodology to analysis, and let's see. One, the workload was measured using objective measures, as we mentioned earlier. All the days were included, and the intervention was, the analysis was blinded toward intervention arms, and it was repeated for adjustment of the day for the weekday and weekends. And there was also a post-hoc analysis included the confounders factors, namely full moon, summer solstice, and other confounder factors that were mentioned in the article. So yes, there was a proper analysis, despite the fact that there are repeated adjustment and post hoc analysis that are actually not preferred in the clinical trials. Do the data justify the conclusion? Let's see. The conclusion was no evidence of a difference in the workload was found between the intervention and the control groups, basically, and even between the unadjusted and adjusted analysis, or when the subgroups were analyzed based on weekends and weekdays. So let's go back to their findings. As we mentioned earlier, coming to the primary outcome, if you can see here, they did not cross the predetermined non-inferiority margin, although most of the data and the confidence interval are favoring the control group. But again, as they're not crossing the non-inferiority margin, this means they actually show the evidence of non-inferiority, which means there is no significant increase in the workload in the intervention group. Same goes to the weekdays and weekends adjustment. Again, they're not crossing the non-inferiority margin, although there is slightly increase in the intervention group. However, they stated that the p-value is 0.8, which is insignificant difference or relation between the type of the weekday and the increase in the workload. So the answer for this is yes, the conclusion is based on the data drawn from the trial. Now, did the study address the important potential source of bias? And actually, yes, there's a fair list of limitations stated in the article, starting with the lack of the control of the use of the quiet word in other departments, which means that colleagues or even visitors from other departments can come in and say that this day is quiet, and actually a predetermined day to be or to avoid an allocated day to avoid the quiet word. So this would result in bias in terms of intervention. They did not incorporate the microbiology word rounds, and the authors justified this that it was not standardized and it was actually difficult to measure, but it's actually a major contributor to the workload. So this again would have resulted in a bias. Lack of control of other confounding factors, as we mentioned earlier, naming seasonal variation, microbiology samples received, cracked mirrors, and other weird belief. So the margin of non-inferiority was subjectively derived, as we mentioned earlier, and randomization was not stratified. Finally, it's a single center trial, and it was conducted over only a 2-month period. So there might be a limitation in generalizing the results to other fields or exterior generalization. So yes, there was a list of limitation in the article. Are there any conflict of interest? And the article clearly mentioned that all authors signed the form of conflict of interest disclosure, and they clearly declared that there was no organizational support or funding or interest in the submitted work to influence the work actually. So no, there was not a conflict of interest. Now we reached the full 13th set of questions. Let's recap. So let's start with that. The article was actually well constructed and well reported following the Spirit and Consort guidelines, and that it actually has a relevant and well-developed question describing all the elements of PICO module. And it actually had the proper design for the type of the research question. And they had a predetermined non-inferiority margin. However, that non-inferiority margin was subjectively derived. And then the sample size was measured in a busier period, and then It was applied in a quieter period, which means the sample size was quite adequate. However, they excluded the microbiology ward rounds, which was a major contributor to a workload. And then the intervention was not told to the colleagues in other departments. However, other departments could have affected the intervention by saying the word quiet. So there was no control over other departments. Intervention was witnessed by all the team members to ensure correct intervention. However, there was no control over the tone or the enthusiasm by which the word was uttered. This is not a weakness per se, but it could be a contributor factor. Again, according to the analysis, it was properly carried out. The analysis was blinded to allocation of the intervention. However, there was lack of randomization stratification, leaving a chance for imbalance and influencing the outcomes. Analysis was then repeated for adjustment of weekday, and there was a post hoc analysis including the confounding factors. However, there was no control over the confounding factors in general. Okay. Finally, I'll conclude with that this trial is a single center again, and it can be generalized. However, it was a good and interesting trial, to be honest. So let me know what you think and if you have any questions. Thank you.
Thank you very much, Tasneem. That was amazing. So we'll leave the questions to later when we'll have some discussion. But for now, in the interest of time, I would have the faculty take down some notes, and we'll move on to the next presentation. So we have a back-to-back. Tasneem and residents who have any questions can also discuss this later. So the next person who's going to present is from Team Unity, and they are going to be presenting text messaging to improve resident knowledge. I'm not exactly sure how far that could be useful, but I for one, am interested to find out. So the person representing Unity is Muhammad Al-Amin. And I'm just going to try to take control back 1 second. Amin, are you around? Let me see.
Sanjay, good morning.
Awesome. All right. Sorry, couldn't see your name for a while there. You have controls and the floor is yours.
You want me to choose the clean screen, right? It's the better one?
That'd be better.
All right. Okay, can I start? Or?
You can. Sorry about that. Technical difficulties.
It's okay, no problem. So, all right, good morning, everyone. Thank you, Anzal, for the nice introduction. And I would like to extend my thanks to all the faculty members who decided to join us in this activity from Tawam Hospital and from Zayed Military Hospital. Also, I would like to welcome all our colleagues from Tawam Hospital as well as from Zayed Military Hospital. So today I will be presenting on behalf of Group Unity. Me and my colleagues Ruqayya, Isra, and Muhammad Isa. Our topic today is about text messaging to improve resident knowledge. It's a randomized controlled trial. This study was published in the Society of Teachers of Family Medicine in January 2015. And this is the abstract of the study. Basically, they sought to evaluate whether text messaging could improve medical resident knowledge in the musculoskeletal medicine. And we're going to mention about why they chose the musculoskeletal medicine in a bit. And the method that they used is basically, as I mentioned, it's a randomized controlled trial. They included 11 United States family medicine residency programs with a total of 269 residents. And the intervention used was the electronically generated educational messaging system. And the result, only 63 residents completed the pre-test and post-test, and they concluded that the use of electronically generated educational messaging system as initially developed did not actually increase resident knowledge based on the exam scores. So let's dissect the study. First of all, talking about the PICO, the research question: does text messaging improve family medicine resident knowledge in musculoskeletal medicine? The population included, as I mentioned, 269 residents from 11 United States residency programs through University of North Carolina School of Medicine. They were the organizers. And the intervention introduced was the text messaging educational intervention in graduate medical education programs. And the comparison, which is the intervention, was given or was actually tested in the intervention group, which is the electronically generated educational medical messaging system, and the control group did not receive it. And the outcome was the knowledge of musculoskeletal medicine as measured by the score on the 30-item multiple choice examination on both pre-test and post-test examination, calculating the difference and seeing whether there is a significant improvement from the pre-test to the post-test results. So let's ask this first. Does the study ask a clearly focused clinical question? Actually, the clinical question research is only partly defined in the article. However, the paper clearly defined the population of interest, the nature of the intervention, the standard of care to which the intervention is being compared. Also, the clinical outcomes of interest were mentioned in the study. Does this study add anything new? Data about previous text messaging effect on knowledge are scant, actually. It is the second RCT about this concept and the first among medical residents. The study extended the notion to new population because only there was one randomized controlled trial which checked for the improvement of knowledge through text messaging. And as per their article, there are no published trials evaluating a text messaging educational intervention in graduate medical education programs. This is the study which was published in 2012. It was the first RCT to evaluate whether text messaging improve in knowledge, and it was mainly done for preventive healthcare topics, and it was deemed to be helpful in improving the knowledge. Is the study design appropriate to the clinical question? Yes, it's a randomized controlled trial, and it forms the hallmark of the evidence-based medicine, as we know about the randomized controlled trial, to inform the basis of transforming the research data into more clinical practice. Talking about the study design, as we mentioned, it's an RCT and the interventional development. First of all, the participating program, 11 family medicine residency program participated in this study. At least one faculty member from each program was part of the research collaborative. And how did they select the topic for the intervention? The revision of the MSK, musculoskeletal medicine questions from 2009 to 2011 national in training examination data from the American Board of Family Medicine was done. And then they chose the musculoskeletal medicine because it is one of the lowest scoring content in the American Board of Family Medicine. And the knowledge test consistent of 30 musculoskeletal content questions was generated. So this was the intervention, a 30 musculoskeletal content question used to generate the electronically generated educational messaging system. And how did they develop the electronically generated educational messaging system? Basically through testing the discriminant validity of the exam by having 2 sport medicine physician and 6 first-year medical students complete the exam. After that, based on the items on the knowledge test, members of the collaborative developed the corresponding text message in question and answer format. And this is a sample or screenshot of the electronically generated educational messaging system with sample text message. As we can see here, the text messaging was sent to the intervention group at 11 a.m. with answers at 3 p.m. and it is a shortalized representation of this sample question. As we can see, it's a very long question, and they would send only the text messaging, and after 4 hours they would send the answer. This is after both groups received the pretest. So were the groups similar at the start of the trial? Basically, more or less, they were the same. We can see like total number is 140 in the control group, and which included 5 programs, and in the intervention group, the total number was 129, which includes 6 programs. On more or less all of these variables, total resident number, rural or urban, university or community-based residency program, they were the same. Some differences that worth to mention is basically male resident percentage was more in the control group. It was 55%, while in the intervention group it was only 44. The international and medical graduate percentage also were higher in the control group as compared to the intervention group. And to make the study more equal between the two groups, there was a sport medicine fellowship, 3 in the control group and 3 in the interventional group. Let's talk about the characteristic of the participant resident at the baseline. They mentioned the main differences that the BGY2 or the second year resident, they were a little bit higher in the control group, 41 versus 34 in the interventional group. Also, there was male predominance in the control group as compared to the intervention group. And self-reported knowledge of the musculoskeletal medicine men on the scale of 1 to 10 was similar, as well as the baseline test percent correct was also similar between both groups. So this was not significant as in terms of superiority. And then, is the study adequately randomized? So the randomization and the study procedure, let's talk about how did they randomize the sample study. 11 program names were written on a folded cards, then drawn out of group and placed alternately into 2 piles. And then a coin flip was done, which determined which group became intervention and control. And the randomization at the institutional level was chosen over the individual level to avoid contamination by resident sharing or discussing text with those in the control group. And although this is a multi-center trial, which usually the best thing to do for multi-center trial is to use a computer-based centralized randomization. However, this is considered adequate for this study. Talking about the internal validity of the study, are the results of the trial valid? No, because no difference in the groups related to the intervention observed. In other words, the causal variable did not produce the effect, maybe due to high dropout rates, also because of other threats to the internal validity, which include the biases and random errors as well. Is the level of blinding reported? There was no mention about any blinding, and it's obviously non-blinded studies. Subjects basically were aware which groups they went into, so which could resulted into performance bias. Also, there was some selection and attrition bias, which represented by high dropout rate. As we saw, there was 269 who initially joined the study, and then only 63 deemed for the analysis for the study, which completed both the post-test and the pre-test. And they mentioned that to be able to link the baseline test result to the post-interventional test result, residents were giving or asked to generate a 3 personal code so that they can link the pre-test and post-test result. And actually, after the first test, answer was not provided, but after the post-test, which is the post-interventional assessment, the answers were provided at the end of the test. What are the outcome measures? This study had both primary outcomes and secondary outcomes. The primary outcome of the study was to measure the knowledge of musculoskeletal medicine as measured by the score on the 30-item multiple choice examination. The pre-test and post-test were administered at baseline and again 6 months later using a web-based survey system. And the secondary outcomes included the self-rated comfort level with musculoskeletal knowledge on a scale of 1 to 10. Also, how frequently residents use cell phones to look up medical information on a scale from 1 to 10 was a secondary outcome. Were all participants who entered the trial accounted for? From the 11 programs, a total of 269 family medicine, which, as we mentioned, were invited to participate in this study, 140 in the control group and 129 in the intervention group. We can see here a significant drop rate that I will mention about here, where all patients who entered the trial analyzed in the groups to which they were randomized. As we can see here, 269 invited to participate. Only 177 residents completed the pretest. And then they were randomized to the control and intervention. 76 of them who were randomized to the control group, only 20% of them completed the post-test. And from people who were randomized to the intervention group, which they included 101 residents, only 43% of them completed the post-test, and actually only 32 of them received the text message, which is the intervention. So overall, only 63 completed both the pretest and the post-test and were considered for analysis in this study. And as we mentioned, only 33 of the 43 who in the intervention group actually opted to receive the electronically generated educational messaging system. And among the residents who participated by using the electronically generated educational messaging program, only 30% of them reported reading all of the text messages, and 44% reported reading almost all of them, which is not bad. Only 6 of participating residents reported reading none of them. What were the results of the study? As we can clearly see here, the performance on the post-test increased in both groups. As we can see here, the intervention group only they included 32, and the control only 30. In the intervention group, the pretest percent correct was 55, which jumped to 64 with a significant p-value in this intervention group. Also in the control group, the pretest percent correct was 56, which jumped to 61% with a significant p-value as well. However, the difference in the improvement between the two groups was not statistically significant. So the intervention did not produce a significant increase in improving the knowledge of the residents. Moving into some calculation, we did some calculations. The relative risk is almost 1, which means that there is no difference between the two groups. Thus, text messaging had no effect in improvement of knowledge. And the absolute risk reduction we calculated to be around 3%. And that is concluding that the absolute benefit of text messaging is only 3% improvement in medical knowledge. And the relative risk reduction is 4.9. And that means text messaging reduced the risk of low score by only 4.9 relative to that occurring in the control group. And by calculating the number needed to treat, we concluded that we would need to treat 33 people over 6 months in order to prevent 1 low score. So will this result help me in caring for my patient? Or in other words, the external validity of the study, is it applicable? Similar population, yes, more or less. It is at the resident level or postgraduate medical professionals, but different specialty. We can use it to any specialty. Is the intervention feasible? Yes, it is feasible. Text messaging, it is a low cost and can be used. Will the potential benefits of intervention outweigh the potential harms of intervention? Again, yes, if used correctly and if used, if I said, if residents were involved in the development of the intervention, basically the senior residents, this electronically generated educational messaging system could improve actually knowledge. Let's talk about the strength and limitation of this study. The major strength of this study is that objectives were clearly stated. Inclusion and exclusion criteria also were stated. It's an RCT study, so the cause and effect relationship, and it is generalizable. And one of the major strengths mentioned in the study is that text messaging is not a high-cost intervention. Moving on to limitations. We have some practical limitations that some intervention group individuals did not receive the text. We have some ethical, as always in the experimental studies, because some get intervention and some don't. The internal validity, as we mentioned, the causal variable did not produce effect and most likely due to high dropout rate, we don't know. And the conflict of interest was not stated in this study. More limitations that were mentioned in the study include overall low participation rate, recruiting busy resident, and retention or retaining the resident to complete the post-test. Also, sending text during the day and clinical work could have resulted in lower response rate. And there was no attempt to control for residents who had completed a musculoskeletal medicine rotation prior to or during the intervention. Also, test was composed of 30 questions, which might result in a very long interventional assessment that might lead to fatigue and random answers by residents. Anonymity of the participant can reduce motivation to perform, and also lack of incentive. The use of the same test question for both baseline and post-intervention possible testing effect. And how they try to overcome the limitation. The intervention was seen as helpful during the focus group discussion. The focus group discussion actually included people from the control group residents, 11 resident intervention participants who received the intervention electronically generated educational messages. They were 5, and the intervention non-participant, they were 6. They invited but they did not participate in the text messaging program. And both the control group and the people who did not participate, they were giving an orientation and they were administered to the educational generated to the electronically generated educational messaging system, and they liked the system, and also the intervention participant, they liked that. The second point is that even distribution of programs with sport medicine fellowship, as we mentioned, 3 were in the control group and also 3 sport medicine fellowship programs in the intervention group. Assuming that any added curricular activities would be even among the programs, therefore not affecting the result. This is only an assumption, but could be a valid point. The length of time between tests largely mitigates any potential testing effect that might have been resulted from, for example, here, as they mentioned, for post-baseline and post-test intervention, the use of the same test question. So the length of the time might have mitigate any potential testing effect. To improve or what we can do in the future to improve this study, including resident in the process of creating text messages, allowing users to pick a different topic or time of the day to receive the text, an option to submit an answer with more immediate feedback so that the resident will be more excited and they would get the answer quickly. Longer time period between the pre-test and the post-test might give us, if there is might show us there is like a real benefit of the intervention. Larger study group is needed. Higher participation rate might have enabled detection of a difference between the groups, and providing time away from the other responsibilities to take the test could increase the participation. In conclusion, as residents are using mobile devices for learning on a regular basis, we need to optimize this to for educational research and development. So, however, they concluded that the use of electronically generated educational messaging system as initially developed did not increase resident knowledge actually, based on the exam scores, the post-test and pre-test. And further study, of course, is needed as the resident liked this intervention. And however, when another further study is being conducted, this should be involving the resident choosing the topic, timing of delivery, and response option is warranted. And further study is needed to determine if a more tailored intervention is effective. This is our references. This is the citation of the article, and actually we use the Center of Evidence-Based Medicine paper or sheet to critically appraise the RCT. And thank you everyone for listening, and we are done.
Awesome stuff. So this text messaging is normal text messaging, right? Not WhatsApp.
Yeah.
All right, thank you so much. I mean, that concludes the resident team presentations from side, and we're gonna move on to the next theme that has a slightly more philosophical question to ask about de-stressing. It's SAMA. I know it's a very long name. Show up against medical advice, presenting randomized trial of therapy dogs versus deliberate coloring. Is that it? Art therapy to reduce stress in the emergency providers. So presenting this is Alia Hadid, and if I'm not mistaken, Alia, you are also in R1.
Yes.
I don't. Awesome. All right. So the floor is yours, and we're glad to have you here. So ready when you are.
Thank you. Can everyone hear me? Yes. Okay, great. 1 second. Do you guys only see my screen or is it? Okay. I'm sorry, I'm having trouble. Where is this? How can I get rid of this? Can I
So
get
what
some
you could
help?
do is you could probably collapse that.
Oh,
There's
there.
two
Okay.
arrows going inwards, and that should help. Don't worry. You have 5 minutes for technical issues.
Okay, 1 second. Okay, right there. I'm just gonna go right. Okay, so sorry about that. Good morning, everyone. Greetings to all Zayed military and faculty. Thank you, everyone, for being here. My name is Ali Hadid. I'll be presenting Show Up Against Medical Advice. My team is going to be Amani Abduli, our senior resident, Rashid Saleh, and Abdullah Bash, and myself. So we're critically appraising the study, randomized trial of therapy dogs versus deliberate coloring or art therapy to reduce stress in the emergency medicine providers. Okay, conflict of interest. We do have cat people in the group. I'm personally a dog person, so I might be a little bit biased. So we all work in the emergency department. We know how stressful it is, especially during these days, COVID. People are yelling, everyone wants their thing to be done at fastest. We are at risk for burnout. Everyone knows that. And as rewarding as emergency medicine is, I guess that's why we're all emergency physicians here, it's undeniably marked by a high level of stress. We rank at one of the highest levels compared to other specialties at 70%. And it's not just that burnout makes us not want to go to work or just be tired. No, it's going to affect our empathy towards the patient. It's going to affect patient care. It might cause shorter careers in medicine, and basically our goal is top-notch care, so we don't want that to be affected. Our clinical question is, does dog therapy, or basically playing with a dog, result in lower perceived stress than deliberate coloring or control applied as a break during an emergency medicine shift? So the clinical question, why did they go for dog therapy and art therapy? Basically, there were a couple of studies that showed that playing with an animal, specifically dogs in a healthcare workplace, or taking that break with a dog could basically lower stress levels. In addition to the fact for art, their justification was basically as a mental distraction to override the cognitive stress response. Dogs, we all like dogs. A lot of people like dogs. I hope you guys like dogs. And some of us like art, more chill kind of thing. So this is the paper we used. I read the title already. It's a randomized, single-center, randomized prospective controlled trial. This was very recently published in April 2020 in the AEM, which is the official journal of the Society for the Academic Emergency Medicine. We'll go into details of the study in a bit. Technically, are the results valid? That's our main question here in critical appraisal, right? And we have to be careful to make sure that we know the difference between valid and reliable. So reliable is basically, if we do it again, it'll have consistent results. But for valid, we're basically looking at the instruments used and are they really measuring what they're supposed to? We'll start off with some questions. Did the trial address a clearly focused issue? In our opinion, yes. This trial talked about stress in the emergency medicine department during shifts. It did. So to go more into those details, we're going to be using the PICO system, which is the population, intervention, comparison, and outcome. So the population, this was a single center in Indiana in the United States, and took the emergency medicine providers in their emergency department between May 2018 and August 2019, over 7 days a week, weekends, weekdays, between those who had shifts between 7 a.m. and 2 a.m. 47% of those were residents, 23% were attendings, and they even included nurses, 30%. Who they didn't include, people who disliked dogs, who had allergies, had fear of dogs, things like that, which is basically a negative point in our opinion, because if you can't apply it to a whole population, then intervention. So dog therapy, basically you had a 5-minute interaction with a dog and the handler. You could pet it, you can, stay away from it. It's there, you can do whatever you want, as long as you're not harming the animal or the handler, of course. And art therapy, which is coloring one of 3 mandalas or small pictures, which I will show in a bit. And both activities happened in a quiet room, no windows, no phones, secluded from, the hassle and all the noise from the emergency department. Both happened for around 5 minutes. I think dog therapy was around 20 seconds. The mean time was around 20 seconds longer. Comparison was a convenience sample of providers that were not offered any breaks. That's also a downfall. Convenience sample can be biased, right? So basically what they did was they took these control groups, and 5 minutes before the intervention, before the shifts, they had measured their stress levels using the visual analog score, the perceived stress scale, salivary cortisol levels, and the FACES score. And then they had let them know which group they're going to be in 5 minutes before they went to this room where they got their break. 30 minutes after this break, they measured all of these things again, and then once again at the end of their shifts. So basically the outcomes, you have primary outcomes and secondary outcomes. The primary outcomes were the results technically of the visual analog scale and the perceived stress scale. And the secondary outcomes were the cortisol levels and the FACES score. They had also asked the patients to fill in a survey of 10 questions of the empathic behaviors of the doctors before and after. They found no difference. Okay, so we'll go into more details now about the PICO elements. So population, they put in this table, but if you look at the numbers, there's a discrepancy between the control dog and coloring groups, nursing, gender, race, age, and shifts. And we all know that depending on a role, we may have more or less stress. Gender-wise, the shifts, everyone knows that some shifts are busier than others. And they just didn't provide p-values for us to know if the differences were significant enough or not. Were the patients adequately randomized? No. In our opinion, we don't think that happened, because technically they had printed random sequence for 80 of those people. I'm sorry, I didn't mention that. They had a total of 127 patients that they had approached earlier to make sure they are willing to participate. 5 had dropped out because they thought that their shift might be too busy, and we remained with 122. So it was around 40, 40, 40 for each group. 80 of those they had approached, made sure that they were going to be on the shift, received printed random sequence, and that's how they were either allocated either to the dog group or the coloring group. And then the convenience sample, the other 40, were taken according to whoever was there. Was the randomization concealed? We're not really sure. Were the patients aware of what treatment or what therapy they're going to get? Yes, they were 5 minutes before they went in. And I can only imagine, I mean, as a dog person, I'd be really excited. It's like, oh my God, I'm going to go play with a dog for 5 minutes, and then being randomized to the coloring group, which actually causes more stress for me. And one more thing we found really confusing. They kept on going and talking about triple randomizing. We're familiar with triple blinding, but they said that they used triple randomizing to try to avoid the nocebo effect for the control group, which is basically trying to avoid the disappointment of not being allocated to one of the activities, which might affect the results. But we couldn't figure out what triple randomizing is per se. Okay, so the methods, I gave you a brief about how they did it before, after their therapy, and after their therapy. They had used these tools. This is the perceived stress scale. This is usually, the original form is taken over a couple of months. The questions tackle a couple of months, but here they had altered the questions to sort of fit in the couple of hours, to fit in the stress scales in the couple of hours. It doesn't say if it was validated or if this altered version was used anywhere else. We think that's a down point. And the tools, basically, the tools here used were basically tools used to rate pain. We all know the visual analog scale, the FACES pain rating scale. They're for pain. So how accurate was it to measure the stress? Results. So we want to look, were all outcomes considered? Yes. And basically, this is talking about the visual analog score. This is about the stress scale, the perceived stress scale. So in the VAS score, basically, in general, they had gone into a little bit more details, which is not shown here. The residents actually had higher levels of stress when using this score than the nurses. In the beginning, though, that was one thing they had mentioned. And when we looked at the VAS, and when they had discussed it also, the dog therapy had ended up with lower levels of stress at the end compared to the other two, but not in the perceived stress scale, the emergency care stress scale. That's what they found. And basically, how large was the treatment effect? This was measured over a short duration, one shift. So in emergency medicine, we want to try to think of things that are more long-term, because burnout is a more long-term thing. They might, the emergency decision might just have been going through a rough day or something like that. But technically, I mentioned it over and over again, were the instruments precise? They assessed pain, so how accurate were they in measuring these? Let's look at cortisol levels. Cortisol levels basically were consistently high at the beginning of the experiment and dropped in all of the therapies, but more significantly in the coloring and the one exposed to the dogs. They also put in the FACES score results. They said it was not very significant. The scores were very low. So just to try to sum it up, basically, can we apply this to our population? How likely is our population going to be understanding towards bringing in a dog to the emergency department? Some patients might not like it. Some doctors might find it nah. And our clinically important outcomes, I already mentioned it. We want to look at more long-term burnout rates or long-term stress relief methods. This study basically only tackled the short term, a one shift kind of thing. And will the benefits are the benefits more than the harms or costs? Technically, one thing to mention is that the hospital doing this experiment had an animal therapy department. So, and everything was certified. The dogs were always there in the hospital to begin with. They had an organization taking care of the dogs. I don't think, I mean, Tawam does, and I'm sure Tawam doesn't, sorry. And I don't think Zayed military does either. So thinking of the costs and all that, we don't think it's really worth it. We need more studies on this before we try to implement it. And at the end, just do you. I mean, they use dog therapy and coloring therapy, and basically we're all human. I don't think any of us would want stress relief on like a scheduled kind of stress relief. I think when we're stressed, when we feel overwhelmed, we should relieve that stress as soon as possible. We usually order food in our department. We go around, chit chat with some colleagues in other parts of the department. Some people might listen to music. Some people might do some breathing methods, like slow breathing. You just got to do you so that we keep our patient care top notch. And thank you. These are our references. I hope you found our study interesting.
Awesome. Thank you so much, Alia. I think that suffices to say that was an interesting study. So thank you for, so that was a great effort. So more on that later, of course. But so moving on to the last presentation of the day, we have, I'm not sure how this name came into effect, but ketamorphosis. Someone really likes ketamine or metamorphosis, but I'm not sure how that factored or combined together. But parachutes to prevent death and major trauma from jumping from aircraft. Again, another RCT. And the presenter here is Reem Al-Gawanme. I'm not sure if I'm saying that properly, but one second. I'm just going to hand over controls to you.
Hello, yes, Reem Al-Gawanme.
Awesome. Okay, all right, the floor is yours, Reem. So you're gonna have a prompt to share your screen, and feel free to take some time to start your presentation.
And as you said, I'm gonna choose a clean screen, is that it?
That makes things a lot easier. So yeah, I'd advise that.
Okay. And I believe you can see the presentation now full screen, right?
Yes, we can.
Okay, excellent. So hello everyone, my name is Reem Al-Gawanme. I'm going to be presenting ketamorphosis, and yes, that is ketamine and metamorphosis at the same time. We're known to be ketamine junkies here in Tawam Hospital, so we went with that. I'm going to be presenting, I'm going to be critically appraising parachutes used to prevent death and major trauma when jumping from an aircraft. Another RCT as well. My group members are Mohammed Zadran, Waddah Al-Yafai, and Sarah Al-Hajri. It's not pressing next. Can you hear me?
Yeah. To click on the screen and then go forward. Yeah.
Okay. So I'm not going to put the full abstract over here. Similar to my colleague Alia's approach, I'm going to try to go with the validity, PICO first, and then validity, and then I'm going to tell you my results. So this article was done between Michigan and Massachusetts. It was published also relatively recently, 18 months ago, and it was also published in the BMJ journal. And I believe it's the first of its kind. So we're going to jump into it. Research question. Our population, or the population of this article, was based on 18-plus-year-olds, rational adults, seated on an aircraft, and willing to be randomized. The intervention from the question is using parachutes to jump from the plane. The comparison is an empty backpack, and the primary outcome is a composite outcome of death and major traumatic injury within 5 minutes of impact. So the research question is to determine if using a parachute prevents death or major traumatic injury when jumping from an aircraft. And just to point out over here, this is a composite outcome, which means either or is considered a positive outcome, either death or major traumatic injury. The importance of the question. Why was this question brought about? There's no previous research whatsoever done on efficacy of parachutes. And however, we do have lots of research highlighting the injuries related to parachute use, and it's often military research. So Numerous medical interventions believed to be useful have ultimately failed to show efficacy when subjected to properly executed randomized clinical trials. And that's what they were trying to do over here. Just based on the general assumption that parachutes save lives does not mean it's correct. And that's what they went for. So they went for the research. They named it as a participation in randomized trials compromised by widely held beliefs about lack of treatment equipoise, parachute trial. And what that really means is they managed to formulate a sentence that really just forms the initials of the word parachute. Nothing really, nothing more. They were just trying to be a little bit fancy over here. So oftentimes when you do a research, you have to first come up with a hypothesis, and ideally you would come up with a null hypothesis. In research, we try to disapprove a null hypothesis. So we provide a null hypothesis, we provide an alternative hypothesis, and then we work on the statistics, and then we try to prove it wrong. So ideally, a hypothesis would be there is no statistical difference between this and that, or etc. However, in this research paper, they decided that the hypothesis is parachute use is superior to the control in preventing death and major traumatic injury. And you would think that's a logical sentence, but it's quite unorthodox when it comes to writing research articles or papers. So they used this sentence, or they came up with this hypothesis based on assumptions of human impact at an average height of a 4-kilometer jump. So they, based on that, 99% of the control arm will be experiencing primary outcome, which is death or major injury. Relative risk reduction would be 95% in intervention arm, and they assumed that based on these calculations, the required sample size to yield 99% power would be around a total of 14 participants. So they aimed to get about 20 participants just in case some of them drop out. So methodology. Population, we talked about the population, 18-plus-year-olds willing to be blinded, willing to be randomized. They used the student's t-test and the Fisher's exact test for the statistics, and the SAS version 9.4. I'm not quite sure if that's a real thing. And the p-value above 0.05 was considered statistically significant here. And I was confused as why the p-value was more than rather than less than. And I believe it's because if we go back, the hypothesis is not a null hypothesis. So maybe it's a double negative effect. If it's not a null hypothesis, then the p-value should be more than 0.5. I'm not quite sure. If anyone has an idea, please feel free to explain it more. So the population, I believe you can see it. I can't see it quite well over here. They screened 92 people, and the way they screened them is the investigators went on aircrafts, whether planned or not planned, if they're just going on a regular holiday. Whenever they were on an aircraft, they would give the person next to them the questionnaire and explain to them the research paper idea and ask them if they're willing to be participated, if they're willing to participate in this research. So 92 total people were screened, 69 were 64 declined, 5 deemed unsuitable, and then, as you can see through this algorithm, a total of 23 were entered the research, 9 completed the intervention, and 11 completed the control group. This is a list of the baseline characteristics between the people who were allocated to the parachute and the people allocated to the control group. And you can see them here trying to see the difference between the age, sex, ethnic group, height and weight, medical history, flight, and aircraft type. And really over there, you can see, if you look at the numbers more thoroughly, you're going to see them plus or minus the same. One other thing they did in this research article was they actually went through the screened people and their baseline characteristics and compared them to our participants. And this is something that's not often done, and it's actually one of the good points over here. So we'll talk about it more in the discussion, but then again, you can look deeper here. You can see some parachute use, frequent flyer as the only statistically significant things. But there's something missing, and I'll talk about it later. So intervention and control, we talked about them. There's not much to talk about it, either using a parachute or empty backpack, really. Outcome, primary outcome was death and major traumatic injury at 5 minutes. Secondary outcome was the same thing, death and major traumatic injury at 30 days after follow-up, and quality of life 30 days after. The results, am I going to talk about the results? So no, I'm not going to talk about the results, not now. I'm going to try to go through the validity questions first, and then we'll talk more about the results. And that's just to get us used to not jumping to, whenever we read an article or the title of an article, not to jump directly to the conclusion and the results, but to actually go through the methodology at least, if we have time to actually go through the full paper and reduce the practice of that jumping straight to the conclusion. Yeah. Validity. Typical questions, they've been repeated over the past 3 presentations. Did the trial address a clearly focused issue? Yes. Jumping from a plane, is it going to save us if we use a parachute or not? Was the assignment of patients to treatment randomized? It was in fact randomized, and that was the first, it was part of the inclusion criteria that the patients or the people should accept to be randomized. However, they were not blinded to the, right before the jump, they were told what they're given. Were all of the patients who entered the trial properly accounted for at its conclusion? Yes. Were patients, health workers, and study personnel blind to the treatment? Not really, no, they were not blinded. They were told what they're given just before the jump. Were the groups similar at the start of the trial? Yes, if you go through the baseline characteristics. Aside from the experimental intervention, were the groups treated equally? Generally, yes, they were treated the same way. So now I'm going to tell you about the results. We didn't finish the questions, but you need to know about the results before we jump to the rest of the questions. Remember those 2 tables I showed you earlier? I actually cropped out the last 2 rows, and as you can see here, the participants and the screened, there's the mean velocity at which they were flying on or flying at is 0 in the participants, while 800 kilometers per hour in the screen, and an altitude of 0.6 meters for the participants versus 9 kilometers in the screened. And as I told you, the way they selected the patients were when they were on a flight, whether that flight was just on the floor, pre-decided, or an actual full flight, they asked the passenger next to them, are you willing to jump at this speed and at this altitude from this plane and be assigned either a parachute or a backpack? And you can see some bias over there, big error over there, that part of the recruitment was on a landed plane, and it was 0.6 meters from the floor. And that's why 69 of the people screened, the ones who were actually mid-air, declined. And then between parachute and control group, it was the same, no difference between their velocity and altitude. And this is the picture straight from the article. If you ask me, this looks like a little bit more than 0.6 meters. It looks like 1 meter, but that's what they said. So results and actual analysis. On impact, death or major traumatic injury, and a mean injury severity score is 0 for all. There was no impact, there was no harm for either parachute group or the control group, and p-values were statistically significant. 30 days after impact, equally 0, significant, and the health status is pretty much the same, 0.9. It's at the border, it's not significant. Look at the readings, they're the same. Furthermore, there was no statistical difference when stratified by type of aircraft or previous parachute use. The average height of the jump, as we said, was 0.6 meters with an average velocity of 0 kilometers per hour, and 0% of the parachutes actually deployed. And that's one of the errors we're going to talk about in the discussion. Continuity of the validity questions. So about the results, the study population included or focused on those in the emergency department. No, that's not a yes. The treatment effect was large enough and precise enough to be clinically significant. They did use the calculations to get the correct population amount for 99% power. However, would you really look into a paper that just has, 14 total participants? Nope, we're not going to look at it. Will the results help in the UAE? Can the result be applied to the local population or in your context? Not in the healthcare sector per se, maybe the extended healthcare sector, where all clinically important outcomes considered. Yes. Are the benefits worth the harms and costs? Unsure. We'll talk about it more. And this last question is added by yours truly, Reem Al-Ghawanme. You will not find it in any CASP or other paper. Is the methodology of this article reasonable enough to base a conclusion on? And this is why we're doing this fancy journal club about not quite scientific papers. And the answer is definitely no. Discussion. So while this research has shown no statistical significance between jumping with or without a parachute, further randomized controlled trials have to be done on higher altitude jumps. This was a novel idea. It was first of its kind, and they have done every step correctly according to research protocol. However, they chose a distance of 0.6 meters. And when they showed you the difference, the baseline characteristics between the participants and the patient and the people who were screened, that's when you can really understand and appreciate why this, as much as valid as this article is, it's not really, it's not going to cause an impact, or it's not something to follow for in normal, regular life. Financial burden. So again, we said there's extensive research about the injuries and the healthcare costs regarding injuries of parachute use, but no research regarding efficacy of parachute use. So if we do conclude that parachute use is insignificant, or it's not really going to cause a difference between that or free diving, then you're cutting expenses on buying parachutes, and you're cutting expenses on the healthcare system from the injuries caused by these parachutes. Limitations of the research. So they showed that there's a survival advantage. According to this article, not using a parachute is equally effective, so people are fine. But no, there's a selection bias, there's multiple biases over here. Higher altitude, we talked about that. More research needs to be done on higher altitude. Selection bias, again, only the people who were sitting right next to the investigators were asked to join the trial. And aside from that, at the end result, most of the people who did participate were part of the investigation team or their friends and families. It was a randomized trial, but it was non-blinded, and lack of deployment of the actual parachute. So not a single parachute deployed upon jumping. And maybe if there was, would there be a difference in the outcome? But in our paper, there were 0 injuries whatsoever. So if we use it at a higher altitude, we need to make sure that the parachute actually deployed. So what is it? You set to do an abstract. Don't just do a random or read a random abstract without going through it and appreciating it, especially if you intend on practicing whatever conclusion is in that abstract. And I'd like to highlight the famous first paper, the French paper that came about for hydroxychloroquine on COVID patients. I believe the number of, I did go through it a while back, the number of patients were not much, and there was a selection bias. They actually ruled out any severe or moderate to severe and severe COVID patients were excluded from the article. So you're using a medication on relatively stable patients. Is that something you're going to follow? Statistically, it showed a good outcome, but is that something you're going to follow? Not in my case. Highlights. So comparing baseline characteristics of screened patients to participating patients can help facilitate interpretation of results. And you saw that in this article. And I believe this is something to keep in mind when writing your own article in the future. And this is straight from the discussion of the article. Lack of equipoise often pushes well-meaning but ill-informed doctors or study investigators to withhold patients from study participation, as they might believe it to be unethical to potentially deny their patients a treatment they wrongly believe is effective. So again, this goes back to we're practicing evidence-based medicine. Just because you have a hunch about something does not mean this is definitely the right way to go. It's evidence-based medicine. Look at the papers, but also look thoroughly through the paper to make sure it is valid and it works in your environment. So to end it, statistics are a tool while study methods rule. Look into the methodology again, over and over. And these are the resources I used. And that's free jumping. So thank you everyone for this.
Thank you so much, Reem. Was that a quote that you came up with? Statistics, what was it? Statistics rule?
Statistics are a tool while study methods rule. I, in fact, took it from my colleague Amani. She used it previously in one of her presentations. I do not know where she got it from, but I loved it.
Awesome. No, it's very good. Thank you very much. So that finishes our last presentation on a slightly very appropriate, but we don't want to go on that tangent today on the hydroxychloroquine, but that's basically why this thing is inspired, right? The evidence-based medicine, we've kind of seen the death of that at this point, and it is an unfortunate thing. So we're the young physicians of emergency medicine. We're going to be taking it out in the future, so we have a responsibility to our patients to be very thorough when we read a paper, and that's essentially why this activity has been put in place. So what I'm going to do now is we're going to take a few minutes break, and we'll take this opportunity to just go over the teams that have presented and let the judges do their thing in the meantime. So in the interest of short attention spans and smaller bladders, we're just going to go through a couple of these, and then we have a survey at the end. So we had team stat in the beginning with Dr. Tasneem, and these were the other team members of the group. In the interest of time, I'm just going to have this come onto the screen rather than stay for too long. We had Unity afterwards, again from Zayed Military Hospital, and they presented on text messaging to improve resident knowledge. We had Sama next, which was Show Up Against Medical Advice, who did the randomized trial for the dogs versus art therapy. And finally, we had Reem with Ketamorphosis, who did the parachutes to prevent. I'm not sure if the further RCTs for this are ever going to be done. I would be hard pressed to find someone who is willing to jump off a plane for more than 0.6 or even 1 or whatever 4 meters. So unless there's like, I guess there's good money and people are stupid enough. So, so again, like I said, we put up an audience poll for the next 5 or 10 minutes. This is in audience poll. This is not going to affect the judge's decision, but we'll just announce the winner of this. This is just a survey for how you guys like the presentation. And in the meantime, what we're going to do is everyone has a break. I believe it's 9:32 right now. At 9:40, we will start with Dr. Mushtaq's lecture. And I'm going to leave the screen on. And what I'm going to do is I'm going to open the floor for discussion. So feel free to ask from your side, resident to resident, about each person's presentation, or you can take a break as you like. So we have discussion for the next 8 minutes. All right, everyone. We're gonna start now. So I think I forgot to mention the fact that everyone did a really good job while I was on camera and we were speaking. I I would wish that we would have a round of applause, but I'm not sure if that's going to be possible in a virtual setting. We've done the best we can with the tools we've had, but at least from my side, I was thoroughly impressed. I'm not one to say, but and I was thoroughly impressed with the fact that this is your first effort, right? So at least I hope everyone's virtually clapping because this was way better than anything I could have anticipated. But anyhow, you guys did great. And hopefully now the faculty are going to be able to fill in our knowledge gaps and we'll have some opportunity for discussion and learning a little bit about a critical appraisal. I'm sure you guys did a lot of self-study while preparing your presentations and it shows. But now it's time to let the experts speak. So without further ado, what I'm going to do is I'm going to hand over to Dr. Mushtaq. But before I do, introductions are necessary because Dr. Mushtaq has been kind enough to fill in on the very last notice, like I said. So thank you very much for that, Dr. Mushtaq. Dr. Mushtaq took under a little background about him if you guys are not aware, especially those of us not from Tawam. He attended St. George's Medical School in London up until 2000. He qualified within MBBS and he did a lot of work at the London Deanery. He has been qualified in the FRChem as of 2010 and he became a consultant thereafter. He's been working in the West Midlands and as an EM consultant and prior to coming to the UAE, and now he is in Tawam as of August 2019, so it's fairly new. So welcome to the UAE as well. And along with this, he is also an examiner for MRChem and interviews for the EM training in the UK. So he's a big proponent of a critical appraisal, to say the least. So he's going to be covering our first paper by Team Stat, the Q fever, or the quiet, the use of the word quiet in the emergency department. And Dr. Mushtaq, the floor is yours, and I believe you have the controls now. Can you hear? So I'm not sure. I can't hear you. I'm not sure if it's something with the one mic or. I could hear you for a bit. Yeah, no. Can you speak? Maybe speak. The voice is quite muffled. Maybe try again.
Can you hear me now?
I can hear you now.
Yeah. Okay. Right. So critical appraisal. So very good talks by everybody. Enjoyed listening to them. Basically, everyone sort of tried to go through a checklist, which is the point of my talk. Traditionally, people sort of fall asleep when you have critical appraisal. I have to admit, it isn't one of my strong points of reading papers, and it's only through being forced to do a CTR and having a critical appraisal in our FRChem exam that I actually really bothered to learn anything, and then probably everything after the exam. So some of this was a bit of a refresh for me. So it's very difficult to try and make critical appraisal interesting, but we'll try our best. So it's important as emergency medicine physicians, traditionally we're not as strong as other disciplines in having basically research out there, although our population and our patient interactions actually probably give us a lot of scope for doing lots of different types of research. And it was one of my reasons to actually go into emergency medicine was that it was less research heavy as compared to other specialties. But having said that, we should really try our best to actually practice evidence-based medicine and actually scrutinize some of the therapies and treatments, investigations we give. Traditional one, people just throw around D-dimers without doing a pre-test probability. So that's like an important thing to remember, or the number of times we just give out antibiotics when we know it's a viral illness. And so not only do we appraise and read the literature, but do we actually follow it as well. So the paper we were given was this one, which actually I quite liked it, the topic itself, because it's one of a bugbear of mine, and many people, I say quiet all the time on purpose just to annoy people in research, and then point out that we're medical professionals, scientifically based, and it should have no bearing on whether you say quiet or not. The other issues are when you work with a certain person, oh, you're toxic or you're not toxic, which again I don't agree with. It's research. It may be busy, so you just got to live with that and deal with it. So already mentioned, particularly by the first presenter, about PICO. And these are usually useful for when you're basically comparing at least one or two, more than two or more arms, and then you put in some sort of intervention in it. And basically it's just a comparison and seeing what the outcome is. And the PICO is an acronym, so make sure you address certain things like population, patient problem, the intervention that you're doing or exposure, and what the groups that are compared, and then the outcome. So the population they'll be part of your selection of the population, who you're targeting, your inclusion exclusion criteria. The intervention is what you're actually going to do or not do in some cases, and then the comparison. And the comparison bit's probably one of the more important parts, because that's where you're going to get your sort of actually, you got to get it in all of them, but when you sort of have your biases coming in, and how you actually evaluate the comparison, and then basically reflecting on the outcome after that. And would the outcome actually help you? So I think in the last presentation, Reem mentioned the abstract. And when we did our exams in the UK, they actually give you a paper without the abstract. And so good practice is to read the paper, don't look at the abstract, read a paper, and then try to write your own abstract afterwards, which is what we had to do in the exam, and then see how well it will correlate with the actual abstract you have. And there's an acronym that you can use to actually write your abstract out, called IMRAD. So why did they do the trial, what method they used, what were the results. The analysis is usually on the statistics, and then discussion of actual whether you can actually use the study or not in your clinical practice. So how to review a paper? So actually there are many checklists you can find online, and the point of the paper of reviewing it is sort of 3 points. One is, what's the point of the study? Why are you doing it? Is it important? Is it relevant? One of my mentors said, if you pick up the paper and it's not relevant to you, throw it away, don't read it, unless you're just doing it for academic purposes or out practicing journal reading. There are probably more important papers you can read. And then the bulk of it is on internal validity. So how well was the study done? How reliable is it? And then the last is going to have something called external validity. So you're just seeing how well you can apply that in your practice or other places. So these are just questions that I'm going to use and try and go through it. So I think in the first one they mentioned 13 questions. I'm not sure how many there are here, but there are different checklists. This one's from the BMJ, look at tick box exercise. This one's from the Critical Appraisal Skills Program. So it's again a tick box, but with further comments. So you can use any checklist that you feel comfortable. But it's more or less goes through the same questions, just slightly different wording and emphasis. So why was the study done? So you can prick that out straight from the paper. A long-held superstition about saying the Q word, whether it actually impacts on the clinical workload. And from this, you'll basically develop your question and your hypothesis and null hypothesis, which we've heard a couple of times. So actually what the null hypothesis is basically that there's no difference, and it's whether you accept or reject the null hypothesis. And in most cases, you want to be able to reject the null hypothesis. That's what you're trying to achieve. But if you get them the wrong way around, it is a bit difficult because it's sort of a double reverse, and you're always trying to think back of how it works. But that's basically what it is. So what type of study they did? So it's a randomized controlled trial. So they mentioned non-inferiority. I must admit, that's the first time I've heard that. If you have a non-inferiority, there's also a non-superiority type of trials you can do. So it's basically saying, is it better or is it worse to do something or not do something? And from the trials, the randomized controlled double-blind trial is the gold standard of what you really want if you're actually wanting to get something useful out of it. And obviously, you randomize your treatment groups. You can have 2 or more arms, and you see whether the effects of the intervention were any good, and you measure them. And there are different ways of measuring them. And then you use randomization as well as blinding to minimize bias and confounding factors, which I'll touch on a bit later. The types of studies. So these are, you can have ideas, opinions, editorials, case report series. You know, when one of your attendings say, oh, I used this last time and it worked. I mean, I don't know how much of evidence there is in that. That's just sort of an anecdote. So you can use it, you cannot use it. It's up to you. And then you get to sort of more evidence-based type style studies. So cross-section studies, case control studies, cohort studies. The first 2 are probably more sort of retrospective. Cohort studies are prospective. And then randomized control trials, which is what you want. And then you can actually review a bunch of them, systemic review or meta-analysis, which is all types of studies, sort of cross-reference and checked and study to see if you can actually get a general common theme out of it, which would help. So what was the population in the study? So this is, if the heading in the top, if it's in red, that's from the actual checklist questions. So microbiology department of a large teaching hospital in the UK. So it's a single center study. There wasn't actually any patients involved as such. But could you, the question is, when you get to the population, which would be part of your generalizability or external validity, can you use this in the emergency department in the UAE? So when you're comparing it, so just because somewhere different, it doesn't necessarily mean you need to reject it straight away. You can still get some common things. Is it medical work? Yes, so that's a common thing. But is it the same type of medical work? No. Is it the Q word here? Do you say it in Arabic or do you say it in English? You know, or can you still say it's the same? So there are different ways of actually generalizing and having external validity to it. It's not just a question of, oh, it's in a different hospital in a different part of the world, so we reject it completely. Then again, you don't necessarily have to accept it wholeheartedly, but there can be some crossover. So randomization basically aims to balance unknown and known. And it's the more unknown that you're trying to actually get over. The blinding should help with the more known factors. And basically confounding variables. So what's a confounding variable? One of the examples I learned early on is lung cancer. We know lung cancer is associated strongly with smoking. It was one of the first actually proper trials ever done in medicine, and the evidence was so overwhelming that actually the research into it was terminated early. But a lot of people who smoke have coffee with their cigarette. So does that mean coffee gives you cancer as well? Is it a confounding factor, yes or no? So randomization should try and eliminate that, because what you're trying to achieve is that you get an even spread of people who smoke and have coffee, or who smoke and don't have coffee. And the other way to do it is to then actually selectively use patients who have coffee and don't have coffee and to compare them. So that's what you're trying to achieve with randomization. I'm not sure if anyone knows what the Hawthorne effect is, but it leads us on to the next bit, which is bias. So there are different types of biases, and the Hawthorne effect is actually probably related to performance bias. So if someone knows you're watching them, they might try harder or better or less harder at something. So if you're going to assess, for example, people who've passed their driving test after 5 years, how well do they drive? If you're watching them in secret, they'll just drive. But if they know they've been assessed 5 years after their driving test, then they'll probably try a bit harder. So you get, that's what's called a Hawthorne effect. So selection bias, obviously, you might just choose candidates that you think will help you in getting your answer. So as the last presenter mentioned, in the hydroxychloroquine trial, they used sort of moderately unwell patients, didn't use the sickest patients. Assignment bias, you might give, if you're giving tablets, you might give it to people who you think are going to be more compliant at taking them. Performance bias we mentioned, and then detection bias is how when you might try harder to look for something when you can't, or the other way. Attrition bias is useful because useful to know, and that's basically due to dropout rate. So people who don't actually fulfill or finish the study that you're trying to do. Reporting bias. Now, some people might think, why would you get a reporting bias? But actually, if you did a study to go out to prove something worked and you actually found that it didn't work, so actually that's evidence to say something that doesn't work, but you might actually withhold publishing it. And actually people out there will not know that actually this intervention doesn't work, this drug or this test doesn't work, and people carry on using it. And actually your study showed that, but you withheld it. So that's a type of reporting bias. How much blinding was this? So in the study that they did, so just a question for people, what's a double-blind study? So it could be two surgeons looking at an ECG, but not generally. So that ways of blinding. So if you don't blind it, then everyone's aware of the treatment or whatever they're receiving. Single blind, obviously, is only usually the patient doesn't know what they're having. Double blind is actually what you really want, is where the patient and the clinician doesn't know what's happening. So you for example, if you're given drugs for a particular condition, you'd have equally looking syringes, same volume, same color, same labeling, so they wouldn't know the difference. So they did that, I think, for one of the trials in the UK, pre-hospital adrenaline and cardiac arrest. So they basically gave fake adrenaline syringes to paramedics to see whether actually adrenaline works. It's actually never been, there's no evidence to say actually adrenaline works or not in cardiac arrest pre-hospital. And then triple blind is that it involves the data collectors as well, where you try and avoid the bias of people who might want to reject some data that they get that they might not like. And usually the way you can do that as well by just getting external data collectors that have nothing to do with the trial, or just number crunchers. Okay. So did the authors lose any patients? So I think a couple of you guys put up a diagram. So this is called a consort diagram, where you're basically looking to make sure that everybody in the study that started it finishes it somehow, and whether there was a dropout rate or not. And that would affect if you had a control group and an intervention group, a lot of people dropped out one of them, particularly the control. If a lot of people dropped out of control group, you're not going to have good control, obviously. And if a lot of people dropped out the intervention group, you're not going to have enough numbers to actually show your effect that you're trying to show. So it's important actually to look at a consort diagram, or at least have some reference to see what the dropout rate was, to avoid attrition bias. Was the study big enough? So in this, you'll use the power of a study. Generally, it's at 80%. And the point of it is that you basically want to have a high enough number that will show you a statistical significance. Smaller studies, like for example, again, the hydroxychloroquine, I think only had 36 patients, very small study. You can't really you know, if you flip a coin 36 times, you might get 25 that land on heads and the rest land on tails. So it doesn't help you as much. And it's to avoid basically type 1 and type 2 error. There's a lot of wording there, but I'll try and simplify it if I can. Study size, if it, to give an example, if you're flipping a coin and you only do it 10 times and the difference is only 2, so instead of 5 and 5, you have 7 heads and 3 tails. So it's a 70 to 30% split just on a number of 10. If you do 100 and you have a difference of 2, then you're going to have 52%, 48%, which makes it look a lot closer, which you expect, because you know it should be half. And if you do 1,000, even more, then it's even closer in percentage-wise. So that's the whole point of having enough numbers in your study to show that there is an effect that's really not happened by chance. That's what you're trying to really show with your study size. So basically, type 1 and type 2 error, you're trying to show that you're not falsely accepting the null hypothesis or falsely rejecting the null hypothesis. That's what you're trying to show. And again, that would come from having enough numbers in your study. So, I mean, this, you know, that might help you to visualize it a bit better. Okay. So people might have mentioned this internal and external validity, and it should be always assessed for that. I mean, that's the whole point of the exercise, really. Using your checklist to check the internal validity, and then external validity is to see whether you can actually apply it or generalize it to other settings. For example, we all use head injury criteria CT scanning from Canada, you know. So that's quite a famous study that people use, and it's quite generalizable, it has external validity. So do we accept the findings of the study? If we were to do the trial again, would you get the same results? And actually, this is a point of science in general, that you do repeated tests or repeated studies that continue to show you the same results. That's actually the basis of science. So if you toss a coin, it always lands. So you know that, but if you tossed a coin and it turned into a butterflies, and it always did butterflies 100 times, then you'd expect the 101 times to turn into butterflies. So that's the whole point of repetition of in science. So actually, a lot of studies you'll have where you'll get finding, and then you have verification studies or validation studies to back it up, whether it actually the study is true or not. And then can you apply it in your own practice? Is it externally valid or generalizable? And like we said, this particular study that the first group looked at was in a microbiology department. Can you use it to say if you work in the ED department? And I explained at the beginning of what you can take from that. So yeah, you could do it. You could do another study in the ED and see if it backs up what they found in the microbiology department. How much does it cost? So this is an important question to ask. And the point of that is, one, if an intervention you're using is so costly that it might not even ever happen. Wasn't mentioned in our particular study that I didn't see. If it was there, I missed it. And also, do a proper double-blind randomized control trial takes a lot of resource. And as a result of that, actually much research is backed by commercial companies and drug companies. And then, so there's obviously a conflict of interest. But does that mean if you find a study that is backed by a major company, do you reject it or look at it with cynicism? You should look at it with some cynicism, but you should also appreciate that actually large studies probably wouldn't have happened without it. So it's not just because a study is done by a company that you're going to reject it completely. But there is obviously chance of biases coming in. They want a positive result for whatever product they're promoting. But it's a double-edged sword really, and you have to find the balance. So actually, one of the things we did in the old FChem style is the CTR, where we looked at number of papers for our topical review. And some of us use scoring systems. There are other scoring systems. There's a Cochrane grading system. There's a Consort scoring system. There's a Delphi scoring system. And you gave a marks out of 5, and you rated your particular studies, and it more or less asks the same questions. This is for our CTs in general, of what we've gone through already in the checklist, but just more brief. So if you wanted, you can always give a JADAD score. There is some subjectivity to it, so everyone might not agree on the same paper having the exact same JADAD scoring, but it's just to make you aware that there are scoring systems out there to help you appraise papers along with your checklist. So that's the end of it, really. If there's any questions, each of these, critical appraisal is a very large topic, and each one of those questions in a checklist, you can do a whole lecture, a whole day's lecture just on each topic itself. I think going forward, probably should just focus on one particular, for example, one day bias, one day statistics, one day randomization, just to see, so you can really get a grasp in detail of each facet of the critical appraisal. So Anzal, I'm finished. Is there anything else?
No, thank you so much, Dr. Mushtaq. No, but you have like about 10 minutes. So anyone who wants to ask you questions regarding the context of your lecture, like for example, type 1, type 2 errors, anything you want to elaborate on, guys, or ask him, this is your chance for good feedback. Also, any comments from or any questions from the presenting team, if they want to ask Dr. Mushtaq with regards to the paper itself?
I have a question, not regarding this specific paper, but regarding the null hypothesis. Are we supposed to always provide a null hypothesis, or can we provide one with the relationship and the outcome?
You need a null hypothesis because it's going to be the actual question of your study, and as you questioned about the p-value, you're using your statistics to reject or accept a null hypothesis. So by definition, you sort of really need one to actually make your stats make sense. You can just use relationships, correlations to show if there is a difference, but how do you quantify that difference? And the whole point of the null hypothesis is show the null hypothesis basically says there's no difference, or if there is any difference, it's just by chance. It's not statistically significant. That's all the null hypothesis is saying.
Okay, so ideally we should always use a null hypothesis.
Yeah.
All right, thanks.
Any other questions? All right. So if no other questions, Dr. Mushtaq, thank you very much for the lecture and the feedback. And we're going to move on to the, you're welcome. Okay. Dr. Mansoor is our next speaker, and he's going to be covering the next lecture that we had from Team Unity. So Dr. Mansoor, just a little background, is he graduated from an Imperial College in 2005 with his MBBS and a BSc in management. He completed EM training in 2014 and worked 5 years as a consultant in St. George's Hospital as well in South London. A couple of his special interests include trauma, education, and training, and he was the ARChem tutor at St. George's Hospital, along with being the education lead for the department. So he's been in Tawam since last summer as well, so relatively new, and welcome again to the UAE as well. He admits that he never really liked critical appraisal as a student and postgrad, which kind of reflects a lot of thinking some of the other colleagues have. However, he's come highly advocated, and hopefully he can give some insight on that paper and some critical appraisal concepts and try to make it a little bit more interesting as well, just for all of us who feel the same way. So during the management degree, he also prepared for the FR Chem exam, and that's basically where you guys are obligated to sort of get into critical appraisal. But I'm sure that in his time since, he's done a lot of work in critical appraisal, and he can probably shed some light on some of the lesser known topics. Boo research by Rashid. Okay, Matt. All right, so sorry, I have been on a bit of a rant. So Dr. Mansour, thank you very much for joining us, especially on short notice. The floor is yours.
Hi guys, thanks for having me, and thanks for that awesome introduction, Anzal. My short version was I'm just another British Asian consultant working in the Middle East, which there's, I think, a few of us around. You guys may have noticed us. So anyway, welcome to the day. I just wanted to start with this clip. Hopefully this will work. It's interestingly some dude talking about the Q word in the emergency department. Let me know if you can hear the audio on this thing.
Each week, some 80,000 Londoners will end up in A&E. When we filmed at St George's, it was quiet. A lull, perhaps.
It's looking okay. The fates have been kind to us this morning. The busload are going to arrive this afternoon, I'm sure, but we're well staffed. We're flowing, everyone's flowing through quite nicely, so fingers crossed we'll be fine.
So a quiet start to the day.
We never say the Q word in A&E. It's a reasonable start to the day, absolutely.
I don't know if you guys got that, but I just thought it was relevant to the last paper. Basically, I think we do have strong beliefs about the Q word. I don't know if you guys got the audio on that. But anyway, we'll move on to my talk. So I just wanted to talk about this text messaging to improve resident knowledge of randomized control trial, which was a Mount paper, which was very well kind of presented and appraised by Team Unity. Basically, we'll talk about Team Unity's appraisal briefly, and we'll. I'm not going to go into too many scoring systems. I apologize. There will be a little bit of overlap with Mushtaq's talk, but we'll talk a little bit about kind of the intro and the literature review of the paper of the Mount paper. We'll talk a little bit about methods and kind of bias in the methods and the methodology of the paper. Mention a little bit about the consort kind of checklist. We'll talk about the results, p-values, and then I'll spend a little bit of just a couple of minutes talking about significance versus relevance in kind of analysis of any paper that you really look at. So just starting off, Team Unity's appraisal. I like the name. Just bring everyone together. I think their appraisal was pretty good. So thank you, Mohammed, Ruqayya, and Isra. You guys did a very good job at appraising a paper. You used a checklist. You mentioned PICO. And you kind of followed the CEBM checklist on randomized controlled trials, which I think is a very good way of appraising a paper. And as Mushtaq kind of mentioned, there are a number of checklists you can use. You went through it in a systematic way. It was good. You mentioned significantly that the dropout rate was different, completely different as far as it was very significant as far as the paper went. So, and I think that definitely impacted the final results and whether you can actually use this paper as a useful paper or not, in your future practice. And then you did also go on and talk a little bit about the further statistics with, RR, ARR, RRR, and NNTs basically. So it's good always to try and do a little bit of your own statistical analysis on whatever stats are presented, because not all papers will mention every relevant statistic that they could. So I think well done, Team Unity, excellent job. I'll move on a little bit and talk about what I'm doing. And this is just a little slide showing the CEBM, just the first page of the checklist that they use for RCTs. I've got the website at the end and you guys can have a look. It gives you a number of checklists in which you can basically just look at different types of trials and just it's a basic, good way of starting kind of your journey into critical appraisal. And as I'm sure my faculty colleagues and I'm sure you guys know that there are many, many ways of appraising a paper. There are many angles you can take. many different checklists to use, and critical appraisal in itself is a huge subject. So I'm not going to go through many checklists. I'm just kind of going to go through my paper and mention any relevant points as we go on. So kind of starting off with the intro and the literature review. So I think it's very important to look at intro and literature review as far as the paper goes, because this sets the scene. It tells you why someone is writing a certain paper, how they're going to go on and write that paper. And this is where, whenever you start on a study topic, you should do a literature search and look at what is out there, what's relevant, what's irrelevant, what's been done before, what's been done well, what's not been done well. In our paper, they cited 11 papers. So those 11 papers, basically, a summary of the literature search was basically, there were 11 papers cited, and basically said that there have been many advances in technology over the years. Text messaging and the use of electronic devices has significantly increased over time, and mobile devices, electronic devices, allow for instant access and ease of access. So I think it's, they're setting the scene. Then the question they were looking at is, can you really use it? Can you really use electronic devices or text messaging or similar kind of media to improve your knowledge? And I think that they've cited certain difficulties as far as clinical practice goes, and more and more we have less and less time to study while trying to provide really good patient care. There's increasing pressure on everyone to provide, to document how they're working, to make sure, and for training schemes themselves to justify how they're teaching, their juniors and how they're improving medical education. There's also a general increase in the comfort of technology in general. We have a new generation. I think they mentioned a bunch of Generation X and Generation Y, and now we have some millennials. Most of you guys will probably come under that category. I suppose I might as well. And it essentially said that, back in 2012, which is, ancient history for some of us, 74% of radiology residents that in one particular paper used smartphones. Now, I suspect for amongst your population, it's probably up closer to about 100%. The other things that the literature review kind of showed were that mobile technology can be effective in patient education, compliance, and behavior. And at that time, their literature review showed it was mainly patient-based stuff, essentially saying that text messaging can improve sunscreen use, it can improve maternal and newborn health, and it can improve adherence to HIV treatment. And they also stated in their literature review that there was no published trials evaluating text messaging as an educational intervention in postgraduate medical education, or in, as far as residents went. So that's how they set the scene and decided that this is the topic that they're going to study. However, there was a certain amount of bias here. There's a little bit of reporting bias in the literature review. There was no foreign language papers cited, and they didn't really mention how they did their literature search, how they got those 11 papers that they have referenced from. So, one of the things in certain papers that you'll read that will say that we used this tool, we used Athens, we used PubMed, these were the search terms we put in, this is how, and these are the papers that we included, these are the papers that we excluded. And again, this was stuff that we kind of had to do for our critical appraisal side, well, actually more for the CTR side of the old FChem exam. But it's always a useful thing to know, so someone can go on, if you state this, then someone can actually go and repeat your literature search and see if there's been any new papers added, if they're kind of truly in-depth appraising a paper. Just a little dig at family medicine, which, I am married to a family medicine consultant, so I don't want to go into it in too much detail, but family medicine it's an up-and-coming field in the UAE, and and with all due respect, they do, with absolute respect, they do work incredibly hard, and they are absolute frontliners, like we are, seeing a whole bunch of undifferentiated patients. So it is in a way relevant to us. So going on to the methods of the paper, we basically did looking at their paper, they picked 12 US family medicine residency programs. And just a point on this, that this is, there's an element of what we call Berkson bias, and this is when you're only sampling a subpopulation. Is the sample representative of the population that you are going, that's relevant to you? So in this case, they picked 12 US-based family medicine residence programs, and at the moment, I'm talking to a sample of 2, UAE-based, Abu Dhabi-based EM residency program. So is their sample relevant to us? Maybe, maybe not. The data was taken from the American Board of Family Medicine in training exam data. Basically, they took some data from there which showed that musculoskeletal the musculoskeletal part of the exam was one of the lowest scoring. And using this, they created a knowledge test of 30 MCQs looking at previous exams. I think it was 2009, 10, and 11. I may be wrong, but 3 years worth of exams, and they picked 30 MCQs from them. And then they basically looked at a primary outcome, and their primary outcome was the difference in pre and post intervention exam result, where they gave everyone the same questions pre, didn't give them the answers, and then after the intervention between the control arm and the intervention arm, they basically did that exam again. And they looked at the difference between the two. And their secondary outcome was self-rated comfort level with MSK knowledge and frequency of mobile device usage for knowledge. This was more of a kind of a subjective, rather, it was more qualitative rather than quantitative kind of paper or analysis of income. The way they randomized was using a coin toss method, which is a reasonable way of doing it. But as Dr. Mushtaq pointed out, that you randomization with coin toss, as with any 50-50 randomization, you need to have a reasonable number for it to really work, and as a true, for it to give roughly 50-50 answers. They took 11 programs and they basically used them they randomized the programs rather than randomizing the people within the programs, and this was done at an institutional level to kind of avoid contamination between residents within the same program. People wouldn't be sharing answers, wouldn't be showing their text messages to other people, which is a reasonable way of doing it. However, there was some sampling bias, which Team Unity did mention, and there were more males and more international medical graduates in the control group. And in the intervention group, they were more rural family medicine programs rather than suburban family medicine programs. Whether this introduces a bias or not, I'll leave that open to you. And there was no blinding, which again, it's not really easy to blind in this type of a situation, so we can let that one pass. They invited participation of both arms of the trial by email, and got people to complete a pre-test pre-test exam. There is a little bit of volunteer bias here, because you volunteer bias, which is a type of selection bias. You basically decide you're going to take part, or you decide you're not going to take part. So you could argue that some of the people who wanted to take part, or who are keen in furthering medical education or interested in the topic, may volunteer, whereas people who weren't keen would not volunteer, and that may impact the results. 2 months after they were invited by email, they basically consented for text messaging, or they were asked for consent in the intervention group. Now, a point that was raised is a number of people did not consent for text messaging, which meant they were pointless in the intervention group, really. The text messages were received every Monday, Wednesday, and Friday at 11 a.m., so slap bang in the middle of your day in a mid-morning period. And everyone received 36 messages, and 30 were basically taken from the exam, and there were six other kind of information points that were messaged as well. Post-intervention, everyone did the same test, and it was basically the same MCQ as the pre-test, and they weren't given the answer at the pre-test phase. And, this time they were given, they were asked to do the same thing. Now, there is definitely an element of response bias here. Not everyone responded. There was a big attrition rate, and the Hawthorne effect is basically the fact that you're being studied might affect your results. So people knew they were in part of the study, might cause them to go and essentially go and and study for the paper, right? And that would, irrelevant of the fact whether they were receiving text messages or not. Then they did a bit of self-rating, looking at people's comfort with electronic means of learning, and then there was a focus group for qualitative feedback. Just a brief overview of bias. This is something that you guys can go and read, but you can remember at different stages of each study, you can have different types of bias. During the literature review, there can be reporting bias, literature search bias. So to exclude this, you basically use a comprehensive search strategy, which you outline, which I mentioned earlier, which they did not do. Foreign language exclusion bias, well, you can translate papers, especially nowadays. A lot of people are publishing in English, but even if they're not publishing in English, you can get those papers translated without too much difficulty. Medicine is a multinational kind of multicultural profession, and we should be open to papers that are not necessarily written in a language that we understand. You can also have selection bias at the recruitment stage, sampling bias, Berkson bias, which I've mentioned, Neyman bias, membership bias, historical control bias, response bias. A couple of these are relevant to our paper. A way to do this is to randomize and blind and to use concealed allocation, which again, it wasn't always relevant for this paper. Other ways of introducing bias into your study is the way you run the trial, and performance bias essentially. And the example of the bias, they use instrument bias and questionnaire bias. Text messaging probably was not the ideal way. They mentioned that each one of the text messages is limited to 160 characters. And it's interesting, when I moved here from the UK, absolutely we use WhatsApp a lot in the UK, but text messaging still happens. And I think here it's partly to do with the fact, and I can't speak for do users, but Appraisal seems to charge you for text messages, whereas in the UK, a lot of your bundles tend to have text messages included or unlimited text messages included. So people do use text messaging a lot more often in the UK than they tend to do here. Then you can talk about kind of collecting data, observation bias, there's interviewer bias, recall bias, response bias, Hawthorne effect, which we've mentioned. The ways to avoid it is to basically use blinding and a couple of other ways of doing it. But again, I'm not going to talk too much about bias because it's been covered a little bit earlier. When it came to analysing the results, which we'll come on to in a bit, there was a huge amount of attrition bias in our paper. And one of these ways to do it is to do exclude it is to do a power calculation and an intention to treat analysis, neither of which were actually mentioned in our paper, which I think would have definitely impacted the numbers that they could have analysed and maybe even the final outcome of the study. Just a point on bias, bias can come from many, many ways, and you can overthink it or you can underthink it, but you just have to be aware that there are ways of introducing bias into not only the paper, but into medicine as well, and into our everyday lives, essentially. So one of the things I just wanted to touch upon briefly was the kind of consort method. And the consort group, and I've got the website at the end, basically is the consolidated standards of reported trials. It's a good checklist. It's 25 items, and you can download the checklist and you can go through it. And it's basically an evidence-based way of looking at your kind of minimum standards to aid in transparency and reporting, and it gives you a method of critical appraisal and interpreting results. And it's something worth considering when you're looking at a randomized controlled trial and just saying that, have they followed certain international criteria, evidence-based criteria, will it allow us to appraise the paper properly, and can we interpret the results and are the results kind of robust? This is just one of the checklists, so this is the consort checklist. Now, each one of these points, if you go onto the consort website, has a paragraph attached to it, and the consort website is excellent. It gives you different tools that you can download and look at. Again, not going to go into any detail with this, but it's something that you guys can look up in your own spare time, and it is a useful way. And if you guys are ever designing a trial or a randomized controlled trial, it's a very useful checklist for you to go through, saying, have I ticked all of these boxes or as many of these boxes as I can? And it makes for a much more robust trial. So the consort diagram, which all trials should really mention, and this is quite an important way of looking at the trial itself. And as was mentioned by Team Unity, I mean, there were 269 participants invited, but ultimately when you get down to it, 20 people completed the post-test in the control trial, in the control arm, and 32 people completed the post-test and received text messages in the intervention arm and the text message arm. So out of 269 people that they looked at, that they asked to be in the trial, they only really analysed 52 people's results. So a huge attrition rate, which definitely is going to impact your statistics, and definitely going to impact whether this trial was actually valid and whether we can actually draw any conclusions from it. Again, now we'll move on a little bit to look at the results, which again, Team Unity did cover in detail, but essentially, if you look at the, 269 people were invited, only 63 completed the pre and post test, again, of which a smaller amount were actually relevant because they received the text messaging. So it was only 52 in the end who could actually analyze. The post-test performance increased in both groups. So there was definitely a significant change with a very small p-value in pre-test and post-test performance. Bearing in mind there was, I think, at least 12 weeks between the pre and the post-test, and they were not given their answers at the end of the pre-test, and the same exam was applied at the post-test. So there's certainly a bias there, because if you're giving them the same paper that they did at the pre-test, people might go off and try and do a little bit of reading as to the pre-test questions, and that that will certainly impact your post-test results. However, the main point is there was no difference between both arms of the trial with a p-value of 0.29. They used a two-factor split plot ANOVA analysis. The one sample, they used a one sample t-test for pre and post-test difference. They used a student's t-test for measuring the difference between the different arms of the trial. And I think the results, as I mentioned earlier, there was a huge attrition rate and there's a response bias between the pre and the post-test results. And the main point is there's no significant difference between the text message between text message group and the no text message group. So the intervention had no significant effect. Just a quick mention on secondary outcomes. I think one of the points to note, which again, Team Unity did mention, there's only 33% of the intervention arm actually read all the messages. There's a huge lack of motivation to participate in this, and there was no incentive given to participate in this. And there's a bunch of points which they again have mentioned in the actual discussion of the trial, which was the time of day the message was received at 11 o'clock in the middle of a weekday. Are you really going to have time to read it? By the end of the day, you're going to even remember that you received the text message, and you're going to go back and look at it. So there was, certainly some errors or issues with the trial there. And the other interesting secondary outcomes were 100% of the respondents used technology for patient care. Now, bearing in mind this trial was a number of years ago, there is a little bit of bias here, because the people who actually participated in the trial all the way to the end might have been the ones who were a little bit more tech savvy or tech friendly and were more interested in the use of technology anyway. And 89% interestingly used text messages daily, which if you compare them to our population now, I suspect it's closer to 99 to 100% of us will be using WhatsApp or a form of kind of online messaging on a daily basis. And then when they looked at the focus groups, only 22 people participated in the focus groups out of 269 odd people invited in the trial, to participate in the trial at the very beginning. Just a quick note on p-values now. P-values and probability statistics have never been my strong point. Again, I did it during medical school, I did it during my management degree, and I had to do it again during my FChem exam, and I kind of get it when I do it, and then I probably go and forget about it afterwards. But these are just some basic things that that it always helps to remember. So very basically, probability always exists in a value of anywhere between 0 and 1. 0, it never happens, and 1, it always happens. And the p-value expresses the probability of the observed results given a true null hypothesis. So your null hypothesis is almost always there is no difference between one thing and another. So there's no difference between receiving text messages and receiving text messages, sorry, and I should say, and not receiving text messages on improving residents' medical knowledge. So there should be no difference between receiving messages and not receiving messages. And the smaller the p-value, the less likely the observed results support the null hypothesis. So essentially meaning that a p-value of less than 0.05 means that the given result is going to occur by chance 1 in 20 times. So if this result happens, then the fact that it's happened by luck alone is only 1 in 20 times. And by convention, we use p-values of less than 0.05, although different papers have used different things depending on the type of paper it is and how robust they want the study to be. Normally, a p-value of less than 0.05 is considered significant. However, in the parachute paper, they reversed it. And in our paper, the p-value was 0.29, so it was not significant. Type 1 and type 2 errors, which have been touched on by Dr. Mushtaq, I'm not really going to mention it too much. Again, it's going very much into statistical details, and I've got a link at the end to a book that's very, very useful, and it will kind of explain these things in a lot more detail. But the short version is a type 1 error occurs when they found a difference when actually no difference exists. And this can be attributable to bias, confounding factors, or testing too many hypotheses. And a type 2 error is basically when hypothesis is accepted when it is false. So basically the study, it's for basically false negatives. Study fails to find a significant difference when there is one, and it can be mainly attributable to the sample size being too small. And so this paper runs the risk of significant type 2 errors because the sample size was very, very small. So again, statistics, never really my strong point, didn't really enjoy it, never really did, I don't think I ever will get around to enjoying it, but it's worth knowing a few basic terms and a few basic things that can take, that it will help you in analyzing a paper. And if you ever need to, there's plenty of online tools that you can use to kind of help revise things. So one of the things I just wanted to touch upon was kind of statistical significance versus relevance in real life. And basically it's the real life application of the study versus whether it's significant, and that's actually kind of the correct analysis of the study results. And one of the things to look at, and it touches on validity essentially, is this trial relevant to our practice? Well, it was done back in 2015 and or it was published back in 2015. We don't actually know when they did it because they were using exam questions from I think 2009, 10 and 11 to build their to build their 30 questions. And so that that's almost 10 years ago, or 10 years ago possibly. And the study was published in 2015, so sometime it was probably done sometime between 2011 and 2015. Now between now and then, smartphone use has significantly changed. Certainly in the 15 odd years that I've been practicing medicine, I remember when the first iPhone came out, and I had kind of an a Windows-based smartphone before all of that, but I was one of these geeky guys who liked having touchscreen phones before the iPhone. And in that time, and now everyone has an iPhone, or everyone has an Android phone, or everyone has some form of smartphone essentially. So there's certainly been changes in smartphone use since 2015. Do we use SMS? Well, again, in the UAE, not really. I think part of that's to do with the confounder that you now get charged for your messages. Or here you often get charged for your messages. We pretty much all use WhatsApp or some other online messaging system. One of the other main things is to look at is the engagement in the trial. It wasn't a great trial because of dropout rate. One would hope that if we are using online learning or some form of messaging way to disseminate information, we'd have slightly more engagement than they had in their trial. Again, we're comparing US versus the Middle East, and we're comparing family medicine versus EM. So I don't know if if this trial is actually that relevant to our practice. A couple of, the 3 points to kind of look at with statistical significance. A trial can be statistically significant and clinically important, and this is when there is an actual meaningful difference between the groups and the statistics support this. So this is a good trial which shows, yes, there is significance, And yes, it is definitely clinically important to practice, or educationally important in this case, which is, this is kind of the gold standard. You want to prove significance, and you want to study something that is actually important and relevant, and the difference will make a difference in real life. However, on the other side, you can basically get something which is not statistically significant, but is clinically important. And this is most likely to occur if your study is underpowered and you do not have a large enough sample size to detect the difference between the groups. You might not detect an important difference between the groups. So in this case of this trial, you could argue it is educationally important. Maybe there are maybe it is important to start disseminating information by a messaging service. This may certainly help us or prompt us to do our own study. It may, clinical pearls and, messages of the day, thought of the day, these kind of things are used throughout different departments and different fields, and they're there to promote kind of thought and learning and prompt people to do their own learning. So, as I say, while I don't think this paper was really well written, I think the idea of disseminating, a little bit of information every day about a certain topic is probably useful. So in this case, this paper may be statistically not significant, but could it be educationally important? Well, maybe. On the other side, you have something which is statistically significant, but not clinically important. And this happens when you have too large a sample size. If you put too many, if you have a huge amount of participants, due to kind of confounding variables and maybe due to kind of poor allocation into the different arms, or not enough standardization between the arms, then you can have tiny differences in each arm. But if you have a huge sample, those differences can be magnified, and then you can detect a statistically significant difference between the two arms, but it's not clinically important because of confounding variables, because of the way you've allocated it, because of the way you've randomized your trial essentially, or the way you adjusted that randomization. So just bear in mind that you might find papers which have statistical significance, but it may not be relevant in real life. This is one of the best scenes from the greatest movie of all time. You guys can recognize the movie, and the maybe not tell me the quote that comes with it. Please message it on the chat side of this, but it is the greatest movie of all time, and I will take no arguments against that. Basically, the main point is to say we all have problems in practice, whether it's clinical practice, whether it's education practice. One hand, we have randomized controlled trials, which are, short of meta-analysis or systematic reviews, considered the most robust ways of looking at a clinical problem or an educational problem in the case of our paper. But you always have to balance this against real-world evidence. And again, in this scene, in this movie, the gentleman on the right wins, and that's because he's awesome. And I think you just have to balance that. Yes, randomized controlled trials are important. They are very useful to add information, but real-world evidence is ultimately what we need to look at in real life, because you can quote randomized controlled trials, but if real-world evidence is going against what they're saying, then you do have to kind of you have to take a step back and say, well, was that trial really relevant to my practice? So coming on to my final views on Mount et al. Essentially, I think the population, apologies for the really small text on this, population was too small and there was a huge dropout rate. They could have fixed this by doing a power calculation, which they didn't do. Ultimately, I think the intervention was flawed and isn't really relevant in terms of our current practice or our current time frame of the kind of era we're living in. The statistics and the statistical analysis was fine. They used appropriate tests. There wasn't a huge amount of statistical analysis done, but it was fine. The findings were not significant, so the paper showed there was no significance. And is it really relevant to clinical educational practice? I should have put a question mark there. I mean, it is. Is it relevant? Yes. Is it relevant to us? Well, it may be. They didn't mention if they had any kind of conflict of interest and stuff. So ultimately, I was a bit harsh, but I don't think it was a very good paper. I don't think it was really useful, but it was an interesting, there's some interesting points raised by the paper and generalized randomized controlled trials, I think. Any questions, anyone? Thank you very much for listening. This is just a list of my references. So the Center of Evidence-Based Medicine, which actually Team Unity used anyway, Consort Group, just a bit of information there, and a paper supporting why the Consort, why the Consort statement and why the Consort set of guidelines is quite useful. And this book at the very bottom is the kind of the gold standard of when I was doing my CTR, my clinical topic review, and my critical appraisal exam. It's a book in the past test series, basically the Doctor's Guide to Critical Appraisal, published by a husband and wife team, Gosal and Gosal. Excellent book, quite reasonably long, but goes into just about every bit of detail you need for critical appraisal and a lot of the statistics as well. So thank you very much. Please don't give me any difficult questions. Thanks for listening.
Thank you so much, Dr. Mansour. No difficult questions here, except for the fact that it's kind of embarrassing to admit that a lot of people still don't know what that movie was. We have a group chat going on. I gave them the hint of Arnold Schwarzenegger, and I don't think anyone has still figured it out.
Yeah, it's sad, isn't it? It just shows my age, but
it's not Rocky. Yeah, there it is.
Thank you. Well,
thank you.
So yeah, it is Predator. One of the best scenes in Predator, and Predator is the greatest movie of all time. And
it is.
Anyone who disagrees needs to go watch it.
Exactly. Thank you again. We do have the floor open for questions before Dr. Asim starts. Any questions regarding this specific research for the text messaging, either from the Unity people?
I mean, I have a comment.
Yep, go ahead.
Hello?
Yeah, we can hear you.
Thank you, Dr. Mansour, for the great talk and for the feedback. I mean, my comment is, yeah, text messaging. I agree. We totally agree with you that the study is not that strong, not well written, and the effort. They use text messaging. I mean, if they used Twitter or another better learning tool, it was done in 2012, and Twitter came in 2006. They're a great initiative, and like medical education initiatives in Twitter, like PalmED, MedEd. I'm not sure how old it is. However, the role of using cell phone for learning, I think it's important. And if we do an RCT today for people who use Twitter as a learning tool among emergency physicians or family physicians or residents, because their knowledge is broader, I think it will show a difference. Thank you so much. That was only my comment. Thank you for the presentation.
You're welcome, Isra. No, I think you're right. I think, there are so many more different tools around. There's a big, big movement of FOMED, and Twitter is certainly something a lot of us use for it now. I mean, I will say this, that I'm a generation apart from you guys in terms of social media and stuff like that. I grew up in a time where, well, Facebook became quite mainstream, but I remember before Facebook, I used MSN way back when for online messaging, and ICQ. These are probably things that you guys have never even heard of, or certainly maybe remember your older siblings or people using back in the day for online messaging. So things have, definitely changed over time. And I think if we were to do a similar paper now, I don't think, obviously text messaging is irrelevant in the UAE and at this time, day and age. WhatsApp is used in lots of different ways of looking at it, and I think this is one of the things you have to look at. I think the idea of using online learning is there, but in terms of relevant to us, we probably will have to stick to media that are a lot more relevant to our in our day and age and our location in the world, actually. So no, I certainly agree.
There actually was a paper that came out in 2018 that looked at WhatsApp as a messaging tree. For example, if they had a drill at any given moment, what's a better way to communicate that information? And certainly you do have a point that smartphones have evolved. Just the other day we had you guys know what I'm talking about, a very interesting video on the immune system. So visual graphics sort of changed the way that we learn as well. So I guess Twitter, Med, WhatsApp is sort of just, converges on a more convenient experience when it comes to learning and information exchange. So I just have one question from my side as a resident. I know we're not supposed to go on anecdotal evidence. I know it's like it's the forbidden fruit of critical appraisal, but what is your anecdotal evidence on the fact that you guys found in your paper the R2s for some reason were a little bit above the rest when it came to the 4 years? If I'm interpreting that correctly, I heard or I saw that there was a slightly better performance with the second years.
I think I'm just going to go back to that kind of bit off the data. I think I don't think it was better performance necessarily. I think there were just more of them more of them participating in terms of the R2s, PGY2s as they called it in the control group. I think they didn't really adjust for the years, and the R2 side of things, PGY2s, there were more of them participating in the trial than the PGY1s and the PGY3s. So I think you could probably argue that maybe they had a bit more time on their hands, maybe their attachments were different, maybe the R1s were, overwhelmed by being in the new residency program, and the R3s were basically too stressed about their final exams. I don't know. I think I wouldn't read too much into it. They didn't really match the postgraduates well. I mean, the fact that they picked different residency programs, it may mean that certain residency programs had more than 1 year to the other year, because these things do vary from year to year and from location to location. So maybe that kind of added a little bit of confounding, a bit of a confounder into the participants, as it were.
That's probably it. I think I misheard that. So anyhow, without further ado, thank you, Dr. Mansoor. If there's no other questions, we're going to move on to Dr. Asim. So Dr. Asim is going to be presenting the third team presentation, which was from the team Sama. So a little bit of background before we get into it. He is a lot of you guys know him if you've ever worked in Tawam, especially the Zayed Ministry residents. He graduated from Karachi. He's basically worked in 4 different healthcare systems. He's worked in Pakistan, Ireland, UK, and then now, of course, he's in the UAE. He also completed his training from South London, and he is also ARCM trained. So he had his fellowship from Edinburgh and, of course, ARCM in the UK. Post-fellowship, he worked in St. Peter's Hospital as a quality improvement and department lead. He's pretty passionate about patient safety, quality improvement. So that's right up the alley that what we need in critical appraisal. He received a national award for supporting frontline categories in 2016. He was nominated for Kent, Surrey, and Sussex UK Innovation and Leadership Award in 2017. So beyond this, he's currently attached with the College of Medicine and Health Sciences at Al Ain as a adjunct assistant professor, and he teaches advanced light support and trauma course. And he currently runs the journal club for our Tawam residents. So he's our current counterpart for Dr. Omar in Zayed Military Hospital. So Dr. Asim Naeem, without further ado, thank you very much for joining us, especially on short notice. So a little bit of a background on that. Dr. Asim Naeem was informed very last minute, so he tried to put together the best that he could. So thank you from all of us for joining us on literally a couple of days' notice. So the floor is yours.
Thank you, Anzal, and I'll start with Rich.
I'm sorry, I think your mic stopped working. Can everyone hear you?
Well, can you hear me? I'm sure you guys can.
I can hear you now.
About me being the Tawam, let me say that this is not the first time you can hear me. So you couldn't hear me in the start, is it?
For a while there, I couldn't hear you.
Hello. So let me start by saying that this is not. Okay, fair enough. Let me start by saying that I'm running the journal club in Tawam Hospital at the moment, but this is not the first time that I'm running journal club. When I completed my MBBS degree back home in Karachi and joined my internship, just before joining, I ended up getting typhoid, and I was 1.5 weeks late than the rest of the crowd. So when I joined in, I went to my consultant, the very next day, trying to impress him. I said, listen, is there any research work, audit, anything I can do to help the department? And he said, you know, we've got a very important job for you. You'll be running the journal club. So this is how it started. I ended up then in Sligo just after my internship, which is in Republic of Ireland. I managed to secure a job halfway through the year because one of the junior doctors went on a maternity leave. And the very next day, I again went to my consultant, Donald Murray, and I said that, listen, is there any research, audit, anything going on? Because I'm new, I'm junior, and I want to be involved in. And he said, guess what? We've already decided you'll be running our journal club. Then when I became a consultant, locum consultant in St. Heliers, you know, in the first consultant meeting, I was given the task as well, and to run the journal club. And when I moved over here to UAE, even before I had a chat with the PD, Jay, I knew that I will be landing with this job. And the reason is simple. No one wants to do it. Mushtaq, in his presentation, he mentioned critical appraisal statistics as boring. Mansoor admitted that he doesn't like doing it as well. And I must admit that I don't enjoy it. But the reason I was given this task was because of the fact that I was the newest faculty addition. So I was, and before me, Ali used to do it, but as I was a new member, I was told that this is how it goes. Whoever is the newest member has to do this job. Must admit that I've developed a little bit of interest because I'm not one of those people who enjoy reading research paper in their free time. And because of this, you know, this commitment, this responsibility, I end up at least reading few relevant, you know, research papers and get a chance to critique on them, which is, I think, it's a good thing. Now, must say well done, Anzal, to you and everyone else, all the teams who presented in this meeting. I must say that the presentation by Tawam was the best. As you can clearly see, I'm being biased over here, as the Tawam team is my team. But let us talk about the paper which I've been asked to you know, look at. So when we look at this paper, you know, we'll follow the 10 questions which have been generally followed to critique any patient, any paper, sorry. So is this study relevant to us in emergency department? And of course, I'm talking about the study, the randomized control trial in which whether if you spend 5 minutes in your shift with a dog helps in relieving the stress or not. So is this study relevant? Of course, we all work in emergency department. It's a stressful environment. So it was kind of relevant, no doubt about it. Is this study add something new? Now, if you ask me, I'm not a dog person, right? And for me, if anything, if I'm like most of the Asians and most of the Middle Eastern people, if I'm near a dog, I'll probably will be more stressed. So, you know, probably not something for me, hence a bit of a bias from my side. And I would say that it probably doesn't add something, you know, new. What type of research question has been asked? So it was a, basically it looked at the relationship between two variables, and study design, was it appropriate? So it was a single center prospective randomized controlled trial, and it was a triple randomized trial, which means that basically the participants who were involved in this trial, the individuals who administered the intervention, and also the people who looked at the outcome, none of them were, they were all kept blind. Now, study, was the study performed according to original protocol? I guess it was. And does the study test a stated hypothesis? So it did look at the question. The question was that whether the intervention with a dog or coloring helps in reducing the stress level. And is there any conflict of interest? To my understanding, there wasn't. But looking at the research paper itself, this was basically a experiment involving humans. And whenever humans are involved in an experiment, there's obviously a lot of confounders, a lot of variables, a lot of bias, which will automatically come in. Now, when we start with the, I'm sure you guys can see the screen, the hypothesis. Was there, a question asked in there? So what is hypothesis? Hypothesis is basically a prediction of what we believe the study will find. For example, in this case, when we tap the dog or play with the dog for 5 minutes, would that reduce stress or not? Now, this was a hypothesis is normally is always an empirical statement. So what does it mean by empirical statement? Empirical statement means that this can be verified by observation or experience rather than as a form of a logic or a theory. This is testable, meaning that you can test it and find out whether it's true or false through the study finding. And since hypothesis makes the predictions, it's logical to include variables in the hypothesis. So in other words, hypothesis is basically where we share relationship between dependent and independent variables. And what I thought was that we'll probably, in my talk, I'll go through the variables and the confounders in this study. So what are these variables? So to understand variables, I'm sure most of us have done a similar kind of experiment when we were students. I remember when we were in grade 5, I think, when in my school there was an experiment which was conducted in which we were divided into 2 groups. Division was not randomized. Depending on teachers' likes and dislikes, we were divided into either the group which will look after a plant which will be nurtured in sunlight, or the other group was allocated a plant which will be nurtured in not in sunlight. So what happened was that 2 plants, identical looking plants, were put into pots. One was put in where the sunlight was present in an open air, and the other one, I remember in our class, was put into a small closet where all the cleaning stuff was kept. And it was obviously a dark room. I was lucky to be in part of the group which was looking after the plant which was kept in the sunlight. At the end of the day, we already knew that the plant which was in the sunlight obviously, had a better result. It grew while the other one died off. What we didn't look at, and hence the end result was that if there's sunlight, the plant will survive. But what we didn't look at is to look at the confounders or the variables, and there were lots of them. So the confounders was, I was in the group which looked after the plant which was in the sunlight. Of course, we were excited. We knew that we were gonna be the winners because in our heads it was kind of a competition, so we looked after our plant properly. We nurtured it, we watered it every day, twice a day, and sometimes, frankly speaking, 3 times a day as well. What the study didn't look at was the fact that whether the plant which was kept in the dark, was it watered properly or not, what type of soil was used in the both pots, whether the fertilizer was used in the exact same amount and of quality in the 2 pots or not. It didn't look at the room temperature or the temperature within the closet. It didn't look at the bias which was already there in the participants of this experiment as soon as the division happened. So these are all the variables which need to be looked at, and they have an influence in the outcome of the study. Now, what are the types of variables? So if you look at them, there are these extraneous variables or confounding variables. Now, what are the extraneous variables? Extraneous variables are the ones which are irrelevant or uninvolved to the subject. So these are the ones which could be as a result of of things which are not directly involved in the study. So say for example, in our study, the temperature of the building during the shift would have had an impact. If it is too warm or too cold, it of course will add to the stress value. The noise pollution that day, I remember recently we had a project due to the COVID-19 within our hospital, when a field kind of equivalent to a field hospital was built just outside our emergency department. I had a chance to do one of the nights in D2 area, which is more closer to the construction site. And throughout the night, there was a lot of, hammering and noises you can hear, which of course adds to the stress level. And if someone would have asked me to fill in a similar kind of questionnaire, my answers and my stress response would have been entirely different as compared to if I would have been asked these questions on a different day when the construction work wasn't happening. Now, of course, there are other extraneous variables as well which can affect these kind of studies which involve humans. So stress at home. The day the question is asked, I'm always more stressed if I'm doing a stretch of 6 shifts as compared to when I'm back from my holidays and I'm on day 1. So all these factors will have an influence. Then there are these confounding variable as well. Now confounding variable, which confounding the word itself means something which causes confusion. So these are the variables which basically can influence the changes, the effect of a dependent or an independent variable. And there are lots of confounding variable which we'll go through. These confounding variables could be in the form of independent variable. So what are the independent variables? These are the predictors or explanatory variables which has an impact on dependent variable. Independent variable can be manipulated or changed to have an impact on the dependent variable. Then there are these dependent variable, which is actually the study, this is the phenomenon we are studying itself. Then we have the moderator or the moderating variables. Moderating variable has a contingent, which is desirable or undesirable, effect on relationship between dependent or independent variables. The strength of the relationship between dependent and independent variable will change depending on the value of the moderating variable. Then we have the mediating variables. Mediating variable is in between dependent and independent variable. They basically are exploring the relationship between the both. And then there are also these control variables, elements which can have a strong impact on the results and is constant or remain unchanged. Now we'll try to apply these variables in our study. So we've got the independent variables, which is dependent variable, which is basically the phenomena we are studying. There's a control group. There are these mediators which have a direct relationship between the independent and the dependent variables, and the moderators which have a strong influence on the study as well. So if you look at if you look or draw a conceptual framework looking at the study, the phenomena we were studying was the stress level. So that becomes the dependent variable. And the independent variable will be the workforce diversity. So we're studying the workforce and basically looking into whether to see what kind of stress level will they have if they are exposed to an intervention or not. Now, the workforce diversity is very important. And from that, we means the the background of the workforce. So the number of workforce who are male and female, the from what ethnic backgrounds they're from, what cultural backgrounds they're from, what type of exposure to the relevant department they had in the past. So this all comprise and helps in in shaping the workforce diversity. And the more diverse the workforce is, the more creative and improved performances they will have. Then we have the moderators. Now, who are the moderators? Now, moderators are the ones who have an external influence on the team. Now, these are the ones who, say, for example, are involved in the managerial work. I've personally worked in departments where there was a loss of stress simply because of the pressure being exerted by through the managerial influences. So that obviously has a contributing factor as well, which directly affect the result of our study. So if they were in a lot of stress, this group of participants, because of remember this was a single center study, because of shortage of staff and them being doing more hours than they are contracted to do, or doing more unsocial hours than others are doing, then of course this will have an impact on our study result. Then there are the mediator variables, and this basically shows the creativity and the performance. So as it was mentioned by Alia, the compassion and empathy towards the patient, and that obviously has a direct correlation between the independent and the dependent variables as well. So all these factors or variables are affecting the study results. Then we have the control group. Now, what is the control group? Control group depends on something which basically element which can have a strong impact on the result and is constant and remain unchanged. So what could remain unchanged would be, and will be different in different settings, would be, say, for example, size of the department. So if you are working in a department which is small, is as we called in UK a department which is in the periphery as compared to a major trauma center, then the amount of stress might or might not be affected. Similarly, number of patients seen in that department. So if you are working in a department who during a average a normal shift sees 10 patients, say for example, as compared to a department which sees 50 patients, obviously the impact which will have and the stress will be different, and the type of complexity of the case has an impact as well. And so if the cases are more complex, obviously the stress level will be higher in these circumstances. Now, these variables obviously in our study had an impact on the outcome as well. But how can we eliminate them? How can we control them is the big question. So examples of how to control these variables, one of them, a few of them were used in this study. So randomizing the sample obviously helps. It does not eliminate, but it does ensures or helps to divide all these variables equally into different groups. Restrict entry, sometimes you've seen in studies that they've used restricting the entry to study of individuals with confounding factors. So say for example, select same age group, etc., or matching of individuals or groups aims for equal distribution as well. Now this could all be done when you are starting the study or when you're looking into the study. However, statistically there are certain things which could be done as well to eliminate or to reduce the impact of these variables. And mainly, broadly speaking, you've got two options. You can either do stratification. In simple words, it fixes the level of confounders and produces groups within which confounders do not vary. So after stratification, you use this Mantel-Hassel eliminator, which can be applied to provide an adjusted result as per strata, or you can use multi multivariable model. Now, this multivariable model is used for bigger number of, when there's a lot of strata involved, then you use this multivariable model. And in this multivariable model, you can either use mathematical processes such as logistic regression or linear regression, or you can use analysis of the covariance to basically help in reducing the impact of these variables. I've decided not to go into the details of scrutinizing the actual study, because I felt that the team did a good job in that, and I rather decided to just see what to pick a topic which was actually given to me by Ansel, and try to apply the knowledge of that topic, which is variables or confounders, to see how we can apply it on this study itself. Open for questions.
Thank you so much, Dr. Asim. So yeah, any questions for Dr. Asim Naeem before we move forward? I think it was an interesting study. I think it was one of the more refreshing papers. And I think, as Alia mentioned, it was one of the most recent ones out of all of the four. So guys, any questions for Dr. Asim before, while he's here?
No, I think the study was undoubtedly relevant to our setting, but whether it was relevant to the particularly settings within this part of the world or not, because I don't know how many will agree, but traditionally I've seen, when it comes to dogs or animals, Asians and us are always not that keen to interact with animals, especially dogs, as compared to non-Asians population. So even when I was in UK, I can pinpoint only a few of my friends who were of Asian origin and were fond of dogs, as compared to a huge number of Asians or Middle Eastern people I knew of who were not that keen to be anywhere near dogs. But the relevance of it in a broader term, in view of how to relieve the stress and what could be done, is obviously relevant. Obviously, they use the coloring method, which has proven to reduce the stress level. But as Alia rightly mentioned in her talk, there are other things which could be done as well, and depending on what you are into, so you can listen to music, or for 10 minutes, have a break and I don't know, eat, or go for a small walk get some fresh air, or whatever basically helps in reducing the stress, will have an impact.
That's certainly true. So I guess we can probably consider another study where it's more PUBG and coffee or something like that. So thank you again, Dr. Asim. We're going to move on to Dr. Omar as our last speaker for the day, talking about our final paper.
I just, hello, Anzal. Sorry.
Yeah.
I'd like to just add one comment regarding that study. It's quite interesting, and we can do something of similar, maybe not dogs, but something similar here. And I think it would be nice if we do a crossover. So one of the things is, we weren't sure if some of the people were dog lovers or not, and they were assigned the opposite, so to arts or whatever it was. And maybe if they do a crossover, and where another day the same participants do the control or the other intervention, then it could give a better outcome or statistical outcome.
And I agree. We can shape the study a little bit differently, and obviously it will have relevance to our setting, without a doubt.
Yeah.
Kind of brings us into the purpose of critical appraisal and research days as it is. You read a paper to see how you can sort of morph it into what you'd prefer it to be and what you'd prefer the outcomes to be, and you'd see if that's actually reproducible in your population. As we mentioned, external validity and the fact that is it generalizable? And I think that's what I mean, of course, these papers are not the best examples, but scientific papers basically give inspiration for others to follow either the same recommendation or the same conclusion, or adapt to their own surroundings. So hopefully we'll see a paper from maybe some of our residents in the future on better de-stress methods, because we have very personalized things in the UAE. I know a lot of coffee lovers here, for one. So I'm not sure if it's linked to cancer, but I'm sure there's a lot of people who consume it by the liter. So thank you again, Dr. Asim. Again, no other questions? All right, so we'll move on. Thank you again. So Dr. Omar is our last speaker, like I mentioned. Dr. Omar Ghazanfar, for those of you who haven't seen him around in a conference or an event, or just haven't had the pleasure of knowing him through some kind of training, he's an emergency physician and a consultant in disaster medicine at Zayed Military Hospital, Abu Dhabi. He's pretty well known to us. He's finished his EM training at the Oxford Deanery. He subsequently completed a master's in disaster medicine actually last year. So yeah, Mabruk belated. He has a keen interest, in research and quality improvement projects, and is currently the ZMH Residency Program Researcher and Quality Improvement Project Coordinator. He presently extensively works with local and international forums. He's conducted several research workshops. We had one a couple of months back, actually. And he's been invited as faculty on a lot of a different variety of events. So critical appraisal seems to be a bit of a pet peeve, and hopefully he can provide some insight. Google will help us on what's going on in the group chat, guys. Okay, so Dr. Omar, sorry, I think got disconnected for a while there.
Yes, sorry, IT issue.
It's okay. So wait a second, let me see. You're still presenter, and I think, are you still able to share your screen?
Let me have a look. Are you able to see that?
Wait a second. How about now?
Yeah.
All right. Okay. Thank you very much.
Brilliant. First of all, thank you, Anzal, for organizing the journal club. When you initially came with me with the idea of having a journal club, I was quite interested. And then because all the journal clubs were happening, or all the residency days were happening virtually, I suggested we do a joint one with Tawam. So I actually spoke to my friend Asim. Asim is a very good friend of mine. We used to work together in the UK, and he actually asked me before coming to the UAE whether it's a good place to come. So he had a bit of a tough time in the beginning, but I think he's quite well entrenched in the UAE now. So in terms of research itself, we don't do much research as emergency physicians. I recently, as Anzal said, finished a degree in disaster medicine, and as part of that, I had to do a thesis which was publishable. So actually, I had put a lot of effort in revisiting research concepts and so on. And what I actually found that a lot of us don't like to do statistics. And if you look at a lot of the researchers, a lot of the statistics, they don't do statistics. A lot of the statistics is done by statisticians, which is what I did as well, to be honest. So we actually have statisticians who will analyze the data for you, provided you have done a good write-up of the paper and doing a research hypothesis, etc. So there's that to that part of research. So people worry about the statistics of research. So I wouldn't be worried too much. I mean, I'm currently doing 3 or 4 papers with my head of department, and all the statistics are done externally. So we are not doing the statistics. We are not collecting the numbers. It's all done by external people. So that's So that's one part of of research which you wouldn't need to worry about as a researcher if you want to get involved in research. As part of the residency program, when I started in the UAE about 5 years ago, there's not much going on in terms of research and in terms of even presenting at conferences or posters, etc., or quality improvement projects. And luckily, I think in the last 4 years, we've changed the system quite a lot. We've got projects going on with each resident year group currently, and some of those are publishable were it not for the COVID-19 pandemic, where everything stopped a bit. We've had presentations internationally and in national conferences as well. So we've done well as a group in Zayed military, and I think that's the kind of thing we want to impart to the rest of the UAE residency programs in terms of research and so on. In terms of the papers itself, really good job by all the residents at a first effort. As I've told Anzal, we need to do it more often. So I think the next one's in a few months' time. So it will be very useful for all of us to refresh some of the concepts. A lot of the statistics, a lot of the difficult terms and so on have already been mentioned by all the various presenters. I'm not going to bore you with that. I'm just going to, so all these papers were essentially randomized control trials. So they're all sort of randomized control trials. So I'm going to talk a bit about randomized control trials. I'll go through the checklist and I'll see how how our paper is good or bad or rubbish or relevant or not relevant. So essentially, randomized control trial is a trial where several interventions are given to patients in control groups selected randomly. It is the strongest research design for evaluating health interventions. One of the interventions is the standard of comparison or control. Now, the control can be standard practice, it can be nothing, or it can be a placebo. So in terms of randomization, so if you talk about designing a study begins before you, so you've got to obviously formulate a concept of what you're going to study, identify the study population, and then randomize before the intervention is done to both the control group or the intervention group. So you've got to have a baseline and then you've got to have outcomes. So randomization is quite important, and we'll see why it's very important. In terms of doing any study in any study design. So it allocates participants. Each participant who is present has an equal chance of being assigned to each arm of the study group. It reduces bias and it reduces imbalance in a study, and it increases the validity of a study. And so if a study is going to undergo internal and external validation, if randomization is not done properly, validation wouldn't nearly work. It wouldn't work. It wouldn't be valid in terms of something which is publishable. So before randomization is done, the research coordinators or research principal investigators have to follow a couple of rules. So first of all is to define the rules as to how they will govern allocation. And once the rules have been identified and randomization has been done, it cannot be modified at any point during the study. If it is modified at any point during the study, it defeats the object, so the study becomes invalid then. So what is masking? So masking is a process which essentially can be done at various levels. It is done at the level of the subjects, investigators, care providers, data collectors, etc. in terms of assessing control. So it is depends over the trial, single-blinded, double-blinded, triple-blinded, and so on. So this is fairly important as part of any study. So randomization, as I said, adds validity to statistical tests. So randomization minimizes confounding factors. Masking reduces bias, and it has ethical aspects as well, which is quite important. So if a study is randomized properly, then it will essentially wash out any population bias. It is a randomized control trial is easy to blind, should be easy to blind rather than observational studies. Results can be analyzed with well-known statistical tools, whichever tools you use, SPSS, Strata, etc. doesn't really matter. And the populations of individuals are clearly identified before you start the project. It's expensive. It has volunteer biases. It may not reveal causation. And you can have loss to follow-up attributed to treatment. Patients may drop out. Patients may have, it can be various aspects to it as well. So in terms of is our randomized control trials the only way of, so is that the only way of doing research? So clearly not. It's not the only way of doing research. In fact, in certain types of research, you can't do randomized control trials. So my sub-interest is, for example, disaster medicine, and you ethically can't do a disaster medicine randomized control trial. It's not possible. So if you look at some of the studies done and published in disaster medicine are either or observational studies, or they are prospective studies looking at. So they essentially look at you know, they don't look at randomized. You can't do a randomized control trial in such studies. So so it's not the only way of doing a randomized, you know, it's doing a research project, but it is, you know, it is the gold standard. So in terms of the 10 questions, we'll just go through them briefly, and I'll go through each question appraising this current paper. So I will not go through each thing in terms of statistical data. I will essentially make it a little bit more sort of interactive, in the sense that I would take it into account. If this paper was given to me by my colleague to read, what would I think about it? So in terms of the question itself, is the study question relevant? Does it add anything new? What is being asked? How is the design? Did it address the bias? Was it according to the original protocol? Does it have a study hypothesis? Were the analysis performed as per guidelines? Does the data justify conclusions? And are there any conflicts of interest declared? So we'll talk about the first part. So in terms of, is the study question relevant? So what is a study question in terms of being relevant? So even if all the parts of the study are done robustly, it has good methodology, it's any paper which is published or is going to be published, or you want to publish it, has to have something which is relevant. And is it relevant to my field of work? So in this current study, so I work for the military. So I've been working for the military in the UAE for about 5 years. So is this study relevant in terms of parachute jumping with or without parachutes from an aircraft? Possibly. It depends on where it's going to be used in terms of clinical context. I wouldn't expect a huge change to take place in the military structure for people jumping out of aircrafts without parachutes, because there is a huge liability. There is a liability on injuries. There's a liability, is a medical legal liability. So it may be relevant, but I'm not sure. So I'd be skeptical. Is it relevant to my scope of work? So it might be relevant to my scope of work, because I work for the military, and the military has people who are jumping out of aircrafts, out of helicopters, medevacs, and so on. So it may be relevant. So we'll see how it progresses. Does the study add anything new? So any scientific research is a term standing on the shoulder of giants. So it might not be any study might now have new ideas. It may be something which building on to papers which have already been published. For example, it might be a study published 10 years ago and provide some recommendations. And then you got to restudy it in 10 years time or 5 years time to see if the recommendations have been met, or so it might add something new. It might solidify beliefs, or it may confound issues. So it's variable. So does this current study, the parachute study, add anything new? It aims to. So what they are saying is that there have been no randomized control trials of parachute use till date. And it is obviously a reason for it. People, parachutes are routinely used to prevent injury or death from people jumping from aircrafts, whether it's because of aircraft malfunction, whether it's from military aircrafts, and so on. So, I'm assuming no randomized control trials were done, because there was obviously ethical issues with equipoise and so on. So it aims to add something new, and we'll see if it does. So what type of questions is being asked? So there's a specific question. So, what are they asking? Is the question well developed? Have they identified the outcome, the studied parameter? Are they asking questions about effectiveness of treatment or frequency of events or so on, whatever it might be? So the research question which they've asked is the use of parachute versus a simple backpack while jumping from an aircraft. So in my opinion, it is it's a difficult question. Would a subject jump out of an aircraft without a parachute? What was the height? So I think they've put down 1 meter as a height. So is that relevant in terms of parachute use? Do people generally jump from 0.6 meters or 1 meter from an aircraft? So these are all questions. So does this research question hold value? Is it an important question to ask? I'm not sure. I don't think so. Does it have research value? It might have some research value, but it doesn't have any practical implications in the real world. And as I said, would somebody actually jump out of an aircraft without a parachute? I don't think they will, which we'll come to in terms of the bias the study brings. So was the study design an effective design in terms of how they managed it, in terms of randomization, in terms of picking out subjects, in terms of blinding, in terms of, was it appropriately done or not? So was this study design appropriate for this type of study? Probably not. So it wasn't randomized. So it wasn't a randomized control in one sense, because you knew which arm you're going to be in. So it wasn't really randomized in that sense. Will you, as a subject, agree to jump from an aircraft without a parachute? I don't think so. As you can see, in terms of how they designed it, it was very subjective. So they only asked people who were sitting next to them in aircraft journeys, to the extent that they actually had friends and families. One of the control arms of the study, where they were jumping without aircraft, I'm assuming this was done by the investigators or the friends and families. So it's obviously a huge bias there in terms of how they did it. So there's lots of confounders, lots of bias in this current study. Is the number relevant for a randomized control trial? So obviously we've talked about the consort trial. So consort reporting sort of mechanism. So was the trial appropriation allocation truly random? No. Would the participants been able to know or guess their treatment allocation? Yes, because they knew which arm they were going to be in. So it's not truly randomized. They were not blinded. Outcomes assessed objectively? Probably yes. Were all participants randomly allocated in the final analysis? So there's no treatment involved here. So that's irrelevant here. And were all the participants' data analyzed in the group to which they were randomly allocated? Yes. They used a type of statistical mechanism or a software to use to bring out the statistics. So yeah, so the analysis were okay, but there was no significance to the results in terms of the p-values. So they did mention the biases. They did mention that they used friends and families, which reduces the strength of the study. So in terms of, was the study performed according to the original protocol? Yes, it was more or less. However, I'm not. So there was no real randomization. There was no blinding as such. The number is very small for it to have statistical significance. 23 for a randomized control trial makes me very skeptical about the usefulness of this trial. Was there a clear hypothesis? So it's been mentioned in various lectures that you've got to have a hypothesis. So they mentioned research questions, but they haven't mentioned research hypothesis. What's their null hypothesis? What's their alternate hypothesis, and so on. And when I was submitting my own paper for publication for my thesis, I actually initially it was rejected because the hypothesis was not mentioned clearly. So actually if you look at most journals and you look at their submission criteria, they all require the specific format you need to use for submitting papers to any journal. And part of it is that it needs to have a formal hypothesis. So for me, in my view, although they mentioned research questions, it didn't really state a formal hypothesis in terms of null or alternate hypotheses and so on. Were the statistical analysis performed correctly? Probably. So for the data they have, the data they got from 23 subjects, it was performed reasonably okay in terms of using a statistical tool called, they used a different tool which I use. I use SPSS. So in terms of the analysis was performed appropriately as according to their the software they used. The sample size was significant. I don't think so. The sample number is far less to have a good study. The power of the study is not good. The data was analyzed fairly robustly. Methods were used, but software results were clearly described. Confounders were mentioned. So it's to their, obviously they have clearly mentioned biases, they mentioned confounders, so that is there. Does the data justify the conclusion? So they've studied it. It's a small study. It's a 2-center study. It is a study in which different aircrafts are used, for small aircrafts and helicopters. They've mentioned a lot of data. They've mentioned a lot of statistics. But is it they justify the conclusions? Is there enough data? So I don't think there is enough data. Have the investigators talked at length about statistics because of lack of data? Probably. I am midway in terms of where I stand with this particular question. However, they have mentioned in great depth their weaknesses and limitations in their discussion. Is that something which they will do again, or anybody would do again, or spend money and do again? I don't know. I don't think so. So are there any conflicts of interest? So there's no conflicts of interest. They don't have any funding for this. So in terms of conflicts of interest, you obviously need to look at various things, which looks at professional roles. Will they be getting any financial benefit from it? Will it be used for promotions, for salary increments, etc.? So is there a conflict of interest here? They've declared there's no conflict of interest here. There's no funding involved. They're not getting any money for it, according to the paper itself. Now, one thing I found interesting is that they've tried, so the research is being done in the US, and they've tried to use a registry to register the trial in Sri Lanka. Now, if people don't know about the Sri Lankan registry, it's quite new. So it's only about 11 years old, the Sri Lankan Clinical Trials Registry. So I would wonder, in terms of doing a project out of big centers in the US, in terms of where the authors are, Beth Tekenis and so on, why would they go all the way to Sri Lanka to do a trial registry in Sri Lanka? And they've published in an open access journal, which is relatively easier to publish as compared to other journals. However, it is still the BMJ, so it still has a good power in terms of research. For those of you who don't know, it does cost a lot of money to publish. So journals do get some money. I mean, I'm not saying that about the BMJ, but in general. So if you want to publish somewhere, it's around £5,000 to £7,000 to publish a paper. That's the journal cost. So if you go on to very small open access journals, you can probably publish quite easily as long as you pay. So in terms of, I'll do a brief conclusion. So critical appraisal, in terms of, it summarizes today. So it is a systematic process through which we can identify the strengths and weaknesses of a research study. It enables me, the reader, to assess whether the study is useful, whether the findings are trustworthy. It is so one of the most important components of critical appraisal is careful assessment of study design, as well as looking at what methods of statistical analysis were used, how they were interpreted, and if there were any potential conflict of interest. Finally, each study has to apply to the importance of research to one's own patients, which will help clinicians identify studies. So in terms of, I did a small case report with one of our residents who's R3 at ZMH at the moment. And it was a couple of cases. One of them had only one case report published in the whole of literature, and the other one we couldn't find a case report. One of them was the use of metoclopramide in renal colic, and the other one was looking at hydrazine exposure. So hydrazine, for those you don't know, is a jet fuel. So both of those were published and presented internationally. So it's not just randomized controlled trials which are publishable. Interesting stuff is always publishable as long as it's unique. So take-home message is the same in terms of, it's a systematic process. It's useful for to use the results of a study in clinical practice. It is different study designs are prone to different systemic bias. Whichever study you use, checklists are important, and it is important to analyze correctly and to have a formal hypothesis. Thank you. I'm done here.
Thank you so much, Dr. Omar. Any questions for Dr. Omar?
Hello, Anzal. Hello, Dr. Omar.
Assalamu alaikum.
Salam, Rashid.
Salam. Yes, just wanted to ask a question. Doctor, generally, when appraising an article, do you think like we should go only through the methods and the results without going through the discussion?
So I do. So that's fine. So what I do is, so if somebody gives me a article to read, I first of all see where it's been published. For example, if you've got an article published in the BMJ or the New England Journal of Medicine or the Lancet, you would expect that it's gone through a very robust process before it's actually been published. It can take up to 9 months for anything to be published. So I mean, I look at the discussion. Discussions are very useful to see what the outcome was. And then I look at the statistics is quite important to look at in terms of the methodology itself, to see whether they've used the right statistics, whether they use the right software, whether they use the appropriate randomization if it's a randomized control trial, and so on. So it's very useful to look at statistics. For example, in this current paper, they've talked a lot about the statistics, but if you look at in the grand scheme of things, they only had 23 subjects. It wasn't randomized. So you've got to look at the statistics. You've got to look at what methods they used, and then you've got to obviously look at how they've described their paper and their findings. I hope that helps.
Yeah, doctor, because all the questions that we ask, even the whatever checklist we are using, they mainly focus on the methods and the results. So the discussion part mainly helps with like if there's any other literature they mentioned to back up their result or to compare mainly. They mention sometimes the limitations.
Absolutely, absolutely. So obviously the most important thing in any paper is to make sure their methodology is robust. It's very transparent, and they've got and the statistics has been done well in terms of how they've managed the outcomes in terms of validity. And then and discussion is quite important if it's statistically if it's statistically relevant. So from my point of view, it is really important to read the discussion, because it sort of tells me if it is something which is relevant to my scope of work, whether it's going to change my practice. And then if it is going to change my practice, then I have a quick look at the statistics and the methodology to see if they've actually used the correct methodology, if they used good statistical software, if their data is robust. And then it depends, as I said, it also depends on how which journal it's been published in, because if it's been published in a journal which is a small journal in Cambodia, for example, I won't really be interested. But if it is presented in a New England Journal of Medicine or Lancet, it would be a really useful study. So it also depends on where it's been published as well.
Thank you, Dr. Omar.
Any other questions for Dr. Omar?
No, Dr. Omar, just to add a comment, I believe you said that the research paper was not randomized. In fact, it was randomized, but it was not blinded. Just to mention that.
So it wasn't blinded. That was the only thing, right? So it's like I think that's fair. I don't think you can blind someone to the fact if they're going to be thrown with or without parachute. That would be very
absolutely.
Anything else, guys? Okay. So thank you, Dr. Omar. Thank you, Dr. Mushtaq, Dr. Mansoor, and Dr. Asim. And thank you all for joining us today, despite the limitations of being virtually homebound or wherever you guys are at this point. we've managed to at least have four different experiences on what we could possibly do with 4 different papers. Granted, these were not scientific papers, and inshallah, we will be doing some scientific papers soon. Hopefully, you guys will continue to do your journal clubs as you guys do in your own residency programs. I think the one thing everyone's waiting for is the winner, but before that, the one paper that everyone had a bit of a difficulty with is actually the paper that was assigned to ketamorphosis and Dr. Omar. It was invariably a slightly difficult paper to break down. So I think that deserves its own kind of recognition. And that's it. So there was a survey in the beginning, and there was a judge's decision at the end. So which one do you guys, either through group chat or through voice, what do you guys want to know first? Which team did best on audience poll versus judges? Which one do you want to know first? In my opinion, and in the judge's opinion, of course, they're gonna back me up on this as well. They're gonna go ahead. You guys all did. I mean, I'm no one to say this. You guys did really good. I'm sure they agree. They've been messaging me as well, and they're gonna say it as well. The thing is, this was supposed to be a very amateur effort, and I think we can all sort of come to a consensus. This was way better than an amateur effort. You guys went into statistics. You had a pretty impressive grasp of an understanding of critical appraisal. I'm not sure how you guys came about that, because we're all really just learning and beginners in the process. But you guys probably knuckled down and did a lot of work, and it shows. So thank you very much for the presenters and the teams behind the presenters. I'm sure there was a lot of work that went into this, and hopefully it's going to be a basis for us to grow our evidence-based medicine. So Rashid has said that they want to know the judge's decision first. Okay, so the judge's decision had a 1, 2, and 3. The third place is tied. The first place and so the third place, let's make it a little more interesting. The third place is tied in both the audience poll and the judges. So the third place was tied in both ends, which is very strange, but that's the way it is. The first and second place was different between the audiences and the judges. So without further ado, I won't leave you guys in too much suspense. The first place, as per the judges, Dr. Mansoor, Dr. Mushtaq, Dr. Asim, and Dr. Omar, they agreed, although we didn't have a really big objective assessment this time around. It was more of a casual discussion. First place goes to Team Stat for the paper on the Q fever, using the word quiet in the emergency department and whether or not that correlates to a busy or a toxic shift. So very well done, Team Stat. I'm admittedly biased. I had nothing to do with it. This is Neha, Tasneem, Faria, and Lola. Great job, guys. Our presenter was Tasneem, but the creative team behind that was all of those above. Second place, so first place on audience poll and second place from judges is Team Unity. Also from Zayed, that was presented by Amin and had Isa, Isra, and Roqaya on board. And third place went to Sama and ketomorphosis. I'm sorry, guys, I didn't rig it, but that's the way it is. You guys were tied at the end, third and fourth, which is still impressive on its own, because the thing is, that fourth paper was a doozer. It was difficult to dissect, and you guys did a pretty good job. But I think it's worth it to say, when I say first place, second place, it's like a matter of 1 point each. So I think equally all round, you guys did an amazing job. Congratulations to the winners on the judges side, Team Stat. Do you guys have any last words? Any congratulatory speeches? Any Miss Universe acceptance of the trophy? Or I don't have a physical prize to give you guys, unfortunately. It is en route. It's being delivered to the UAE. And spoiler alert, there's going to be that prize that, at least for this session, goes to both residency programs, but particularly for the residency team that did really well, Team Stat. I know it's not the one that you guys wanted, but it's a book on critical appraisal. It's called Essentials of Evidence-Based Medicine. It's a pretty good book published by Cambridge. It basically covers a very comprehensive, it's comprehensive, in-depth, and it just basically covers all the different types of studies, critical appraisal techniques, methods, and that's it. So yeah, so we got the group chat firing up. Rashid is still in a little bit of disbelief. What's going on here? So yes, excellent job. What we're going to do now is we're going to wrap up the day. I'd invite the faculty and the residents to just, I mean, the floor is open. The day is over. So we were thinking of doing a group photo since this is our first virtual joint academic day that I know of, and we could probably just have a screenshot for all of us, like one big happy family in our friendly competition. A couple of you guys were interested. I'm not sure. You're welcome, Dr. Omar. It was a pleasure. Inshallah, we'll be having our next session in November with Rashid Hospital, and hopefully we'll circulate around to different residency programs. It was very educational, very informative, and extremely fun. And I hope we'll see all of you guys again. So those of you who want to stay for the group photo, feel free. You can just put your cameras on so we can just take a screenshot. If not, it's fine. No one's being obligated to do this. For those of you who were waiting for this to be over, the day academically is over. This is just an end for us to ask any questions that people have been dying to ask throughout the day or haven't had a chance to have answered from either the faculty or the residents. Any job well done, and etc. So I think I'm going to stop talking. I'll leave the floor over to you and wait for you guys to put your cameras on. So I think so far, yeah, we only have a couple people who are properly dressed for the event. And we have Rashid with a cap on, a hat on, sorry.
Yeah, see? You're wearing a collared shirt I couldn't find, but I found the tie. Alas. And the hat to come with.
I know, right? I tried to look a little more formal than I usually do.
جميل يا رشيد.
Hamad Baya. That.
Thank
So
you.
great job, all. Nice seeing all the faces. Dr. Hamid, hello. Dean.
Dr. Mustaq's got his PPE.
Me and Dr. Mushtaq are fighting for the contest, Comic-Con contest.
Ah, was there Comic-Con this year? It was cancelled.
I have no idea. Maybe. You think I should change the hat? I have this here. What do you think, Anza? For the picture. It's a very important.
You want to go for the urban
Show us
look?
the other one. Show us the other one so we can judge.
Maybe the other one. See my amazing hair.
I vote first one.
First one?
I'll go for the first one as well.
Allah, everyone likes the first.
Abdullah has joined the conversation.
Yeah,
for a while.
Yeah.
I think a lot of people are just either on their toilets or in their bed or just indecently prepared. So I think
that's a good one, Anza. Everyone who's not opening their camera is on the toilet, yeah.
I'm just being brutally honest. That's how I see a lot of the conferences that I am listening to. So that's just a confession from me to you guys. Okay, thank you guys for the group photo. What I'm gonna do now is, we don't have to pose really, it's a video. But thank you all for making this possible. Faculty, Dr. Asim again. Dr. Hamid, it's nice to see you again. Why has everyone lost so much of their hair? It's like, I know it's infection control, but like, I think Dr. Asim's French beard is gone. Dr. Hamid, you've got a new hairdo.
It is
Why is everyone so neat?
My wife is my barber, so.
It's a
Oh, right.
do-it-yourself. It's a DIY, you know.
I don't have a wife. No wife.
That shows. so that's how you differentiate. Amin is getting ready for marriage.
Oh, mashallah, طبعا.
Oh, congrats.
Only after Rashid. Only after Rashid. I have to make sure that Rashid is in the right track.
Yeah, we're waiting too long, man.
Rashid, no chance. So you need to, you know, have some other objectives. You can't follow Rashid.
Prove your goals, yeah, Muhammad.
Rashid has his own objectives. From the looks of it, looks like you're in some Mexican country or something like that. Like there should be a beach background in the back.
Wallahi, I don't have a beach back there. Some bags on the top, if you can see. No beach bags.
Books, very educational.
I'm trying.
Isn't there an anime that looks like that? There's an anime.
Anime?
Yeah, it's a one
Yeah, the
piece.
anime.
Oh, Piece, yeah. One Piece.
Yeah.
So okay, yeah, that's
Getting out over here. When are you gonna take the picture and getting very
no,
hot?
so the picture's sort of taken, because what you're gonna do is we're gonna do, okay, sorry, let's take the picture now. All right, so 3, 2, 1, smile. Perfect. Very good. Take care, guys. Thank you very much for joining in. We'll see you guys next
Thanks
time.
all.
Thank you.
We'll
Thank
see
you,
you on the
Azam.
next episode. Shukran.
Bye.
Take care, guys.
Have a nice day.